Hello friends, welcome to the PrepLadder YouTube channel. Hi, I'm Dr. Shonali Chandra, your faculty of Obs Gynae. So Pooja, hello, good evening to you. How are you? And how is everybody? Let's see who's joining us in this session. And all right, Butterfly, good evening, everybody. Yes. So let me give you a broad overview of what we are going to be doing today. And as you know that we've been having this PYQ challenge on the app where the question bank is open to everybody for you to take advantage of so that you can, solve the MCQs, get an idea about what are the, recent topics from which exams are framing questions most of the time. So, Prasanna Goswami and we have Shubham here and we have, I know, apart from just questions, you also have, apart from the academic questions, you also have other questions like Shubham is asking me how to revise. Now, Shubham, if you're specifically asking me for the exam that is upcoming, right, which is staring right at your face, the NEET PG 2026, with such less time to, revise, the strategy depends upon where you are currently. I mean, how much have you prepared already? Are you in a position that you have already read up on the course and you want in the last moment that you should have 1 or 2 revisions of each subject? Now, if that is the situation, then you should be sticking to the LRR that we will be conducting on the app, and it is actually ongoing these days, right? The LRR is getting conducted on the app, so that covers most of your areas. You have your Q banks. We are having test and discussions regularly on the app as well. We are having test and discussions on YouTube as well. So this is my first YouTube session for this upcoming NEET PG. So try to gather questions from as many places as possible. And in that, at the same time, you can refer to your rapid revision notes if you have, or if you have, if you are a Resolve subscriber, you can refer to those notes as well. So the strategy to revise would be to basically, attempt the questions and go back in a retrospective manner. That is what I would do at this point in time, right? So good evening, Heather and Ram and Shoaib and Rani and Afshan and Suman. So I may not be able to take all your names because my chat box is going up very, very fast, right? All right. Where to find LRR notes? So as and when the LRR on the app is getting conducted, the notes are getting uploaded at the same time, right? So you're getting annotated and unannotated PDFs also. So unannotated before the LRR session and annotated after that, right? So that if you miss out on anything, you can get back to it. Now, duration of this class. Thank you. You're asking me what is this class going to involve. So this is basically a challenge for you people, right? Now, what I have done here is that I have near about 35 questions, all right? And these 35 questions are mainly from previous year topics, right? And have focused on the most recent 1 to 2 years exam patterns, right? And they are mostly clinical. Okay, so the idea is that you've solved your PYQs already, so you know you have attempted them, and this time these 35 questions you will find them similar, but then I have tweaked them a little bit or maybe one up the question so that we can see as an exercise basically to help understand how we attempt questions in the exam. So this is more of an, take it more of an MCQ practice rather than me lecturing you about what to read and what not to read, right? Okay, so let's get started then. I think enough of introduction, right? Let's get started. So are we ready with the first question? Thank you, Ram. So let's have a look at the first question. Now, if Ram, you were there yesterday, RR class, then this question you know how you were there yesterday. So a 28-year-old pregnant woman, 24 weeks, she presents with 4 days of intense vulvovaginal itching, burning with thick curdy white discharge. There's an image given to you. There's a clinical profile given to you. Now, when you have clinical profile based questions like that, put your answers in the chat box. I'm going them ahead side by side, and with each question, tidbits I will tell you, as to what to expect, how to attempt questions. So one thing that students get hassled about is when there's an image-based question and they don't straightforward recognize the image. That is one limitation that you face. If you don't recognize the image straight away, and sometimes what happens under the exam pressure, no, you may not be able to identify images. But if the image is coming with the clinical scenario, then it becomes much easy. So I would say do not waste too much time on the image. I mean, if you identify straight away, well and good. If you don't, focus on the clinical scenario. Look at what the options are provided, because when you look at the last line of the questions, when you look at the last line of the question and then you look at the options, you kind of get a hang of the idea as to what this question or what clinical condition could be being asked in this question, right? Like for example, in this question, if I see, they have given me an image, they have given me a profile of a patient with curdy white vaginal discharge. Now, something that you people would miss if you're not reading carefully is that she is a pregnant patient. Okay. Now, curdy white vaginal discharge, when I read, right, and I also know that during pregnancy, vulvovaginal candidiasis seems to be more likely common, right? So, this is candidiasis. I mean, I haven't even looked at the image as of yet, right? Now, on examination, there is vulval erythema, adherent white plaques. This is all going in favor of candidiasis, right? And look at the image. Image is showing fungal pseudo-hyphae, okay? So, image is showing fungal pseudo-hyphae. All right, fine. So, based on this, now you can eliminate oral metronidazole, right? This is for bacterial vaginosis. Metronidazole is not a treatment strategy for candidiasis. You need antifungal agents, right? Now, in a pregnant patient, you wouldn't want to give oral fluconazole. Right, oral fluconazole is going to be contraindicated in pregnancy. We don't use oral fluconazole, right? And then most of the times it is Candida albicans, right, which is going to be treated by the topical agents, topical azole agents. So we have clotrimazole vaginal P series available with us. We have clotrimazole vaginal gels, and miconazole also belongs to that group of drugs only, or that class of drugs only, right? So the correct answer to choose here is not topical nystatin. So those of you who are saying option B and C, those are incorrect answers, right? So those of you who are saying option number D, that is the correct answer. Correct answer is topical miconazole. So I think most of you got answer D as correct. All right. Now, have a look at this sort of question, right? Now, this is a very, very commonly, frequently asked question in your exam about genital infections, right? Now, if you look at this question, there's a 25-year-old female who complains sudden, profuse, offensive, they're talking about foul smell, right? And they're asking you again a profile of vaginal discharge. But instead of asking you the diagnosis here, see, when they frame discharge based questions, okay, like clinical presentation with vaginal discharge, they can ask you, what is the next investigation you would like to do. They can ask you what would be the most likely causative agent, or what is your most likely diagnosis, or how would you like to treat. Whatever they may ask you, you have to first arrive at a most probable, most likely diagnosis. Like for example, in this question, what is your most likely diagnosis? I mean, when you look at the image, this is a very classic image, often repeated image, right? But you can read through the description also. Vulva is inflamed, vaginal walls are red and inflamed, small punctate hemorrhagic spots as shown in the image. So this is strawberry cervix. Very good. This is strawberry cervix. So I can see most of you are attempting. No, it is not chlamydia. First of all, it is not chlamydia. Okay, it is not chlamydia. This is very typical of trichomoniasis. Trichomoniasis. Okay, chlamydia will be more of cervicitis. All right, and here there is more of vulva being inflamed, there is more of vaginal walls are red and inflamed, right? So this is most likely diagnosis here is trichomoniasis, first of all, right? Now they could give you per speculum examination findings, or they could say that a wet smear of the discharge was made. Now remember and recall that the discharge in case of trichomoniasis is typically described as greenish yellow frothy discharge. Greenish yellow frothy discharge. Okay, typically this is the description. All right, so If I were to ask you that, this is the clinical profile of the patient and we have made a wet smear, and instead of this image, I would have given you this image, the wet smear image I would have given you, right? And then I would have asked you the causative organism. What would have your answer been? Trichomoniasis, because you can see in this image, this tennis racket appearance. Can you appreciate this tennis racket appearance? This flagellated microorganism, flagellated motile microorganism, which is Trichomonas vaginalis. Right? So, image-based questions are generally formed around clinical scenarios. Now, coming back to the question, which of the following statements is true in this scenario? So, once you have the diagnosis, you know that there's one infection in which the vaginal pH is acidic, and that is candidiasis, otherwise alkaline vaginal pH, right? So, this is incorrect. pH is not, vaginal pH won't be acidic, right? Now, male sexual partners needed to be treated at the same time. This is absolutely a correct statement, because trichomoniasis is a sexually transmitted infection, right? So, the statement that is true in this scenario is option number B, and that is your answer, that male sexual partners will be needed to be treated at the same time. And absence of pruritus is incorrect, right? There's absence of pruritus in bacterial vaginosis. Otherwise, when you have candidiasis, intense itching is there. When you have trichomoniasis, intense itching is there. And this is not treated by intravaginal clotrimazole, but we will need the treatment strategy with metronidazole group of drugs. Metronidazole group of drugs will be the treatment of choice. Okay, right? Now, let's have a look at this image. Now, supposing I had given you a clinical profile based question, again, let's say vaginal discharge, and I would have mentioned she's complaining of, foul smelling, grayish white vaginal discharge, coating the vaginal walls. Okay, and I would have said that maybe I did a wet smear for this patient, and this is the image, and I would have asked you the diagnosis. What is the diagnosis? Very good. These are clue cells, right? So, these are clue cells. What are clue cells? You can see that these are vaginal epithelial cells with fuzzy borders. Fuzzy borders, why? Because they are studded with these gram-negative rods, right? So, there is altered microflora, right? Bacterial vaginosis. Okay, bacterial vaginosis would have been the diagnosis, and the treatment of choice is again metronidazole group of drugs. Okay. Now, somebody is asking me what would be the drug in pregnancy. Now, when you have bacterial vaginosis or when you have trichomoniasis, you want to treat with metronidazole group of drugs, right? Now, in pregnancy, this drug can be used. It's just that in first trimester, we will use the vaginal route. So, we have metronidazole gels and pessaries. So, we can give by vaginal route, and in second and third trimester, we can give by oral route. So, the same drug will be the drug of choice. Okay. There is an alternative drug to bacterial vaginosis, and that is clindamycin group of drugs, but that is a second line drug for bacterial vaginosis. Okay. Fine. Now, which kit is used for trichomoniasis? See, the kit-based management is the syndromic approach, right? So, syndromic approach or kit-based management is when we are not making, let's say, when we are not able to differentiate whether it is bacterial vaginosis or whether it is trichomoniasis or whether it is candidiasis, and we are not sure, right? So, if you want to treat for vaginal discharge, it is green colored kit. Okay, but when we have to treat for cervical discharge, okay, then it is the grey colored kit, right? So, when we have to treat for vaginal discharge, meaning we have to cover the agents which are involved in vaginitis, it is the green kit. And when we have to treat for cervical discharge, that means we have to treat for cervicitis. We have to take care of the agents that are causing cervicitis, that is chlamydia and gonorrhea. So, we give the grey colored kit. And when we have to treat for PID or lower abdominal pain on an OPD basis, then for according to the syndromic approach, it is the yellow kit. Okay. Now, let's have a look at the next question. A 25-year-old woman presents with amenorrhea for 6 weeks, crampy lower abdominal pain and mild vaginal bleeding for past 2 days. Her vitals are stable. She has a serum beta HCG of 1500 international units per liter. Which of the following will support the diagnosis of ectopic pregnancy in this woman? Yes. All right. So you have 4 options and you have to make the most, you can see that 4 choices are given to you. Empty uterus on transvaginal sonography, presence of adnexal mass on TVS, free fluid in pouch of Douglas and low serum progesterone. So which combination will support the diagnosis of ectopic in this pregnancy? So most of you, I can see that are answering B as the answer. Nobody is saying anything else. Yes, B is the correct choice answer. Excellent, right? So when you have a clinical profile where you get suspicious of the possibility of ectopic pregnancy, how do you get suspicious of the possibility of ectopic pregnancy? Any woman who is in the reproductive age group and she comes with, period of amenorrhea and pain being more predominant, because even in ectopic there can be vaginal bleeding, but that generally tends to be on the milder side, right? So pain being the more predominant complaint, some mild vaginal bleeding can be there. You should always be suspicious of the possibility of ectopic pregnancy, and most of these situations you want to find the location of pregnancy first of all. So ultrasound, which is preferably a transvaginal sonography, is the investigation of choice, isn't it? Now on TVS, the first clue that you will get whether it is possibility of ectopic is there is an empty uterus. So at 6 weeks, of amenorrhea, at 6 weeks of period of gestation, if it is an intrauterine pregnancy, there should be a intrauterine sac visible. If it is not, then it is very likely probability that it may be outside. So first clue would be an empty uterus on transvaginal sonography. Now if along with that you are also able to see an adnexal mass on TVS, now ideally yes, you should be able to see, or we should be able to see a gestational sac in the location of the adnexa with the cardiac activity, but most of the times we don't see it that clear cut. All we tend to see is some adnexal mass, some complex adnexal mass with vascularity all around the mass, right? So that is what we call as the tubal ring of fire sign, as well, right? So most of the times we see a complex adnexal mass. Now, if that we find in this clinical context, then yes, the suspicion of ectopic pregnancy is definitely much more raised. And if I find free fluid in the pouch of Douglas, now if I find free fluid in the pouch of Douglas, that could be in this clinical context some blood collecting in the pouch of Douglas, right? Now, when an ectopic pregnancy ruptures completely, right, when complete rupture takes place, the bleeding tends to be much more. But there's also a possibility which we call as tubal abortion, right? The tubal ectopic, coming out of the fimbrial end and entering into the pelvic cavity. So along with that also some kind of bleeding generally tends to happen collect in the pouch of Douglas. So in this context we can see free fluid in the pouch of Douglas, which will also go in favor of ectopic pregnancy. Now low serum progesterone. Please remember, recall this, yes, in a healthy intrauterine pregnancy, progesterone levels are, tend to be more than 25 nanogram per ml. That's true. And if a pregnancy is not healthy, like for example in aborting pregnancies or dying intrauterine pregnancies or even in ectopic pregnancy, there would be low serum progesterone. But low serum progesterone gives me no idea about what is the location of pregnancy. So low serum progesterone gives no idea about the location of pregnancy. All it tells me is that it may not be a healthy intrauterine pregnancy. That's all. So actually in clinical practice, we're not doing this serum progesterone any which ways to make a diagnosis of ectopic or locating an ectopic or even diagnosing abortions. We're not using low serum progesterone, right? So your 4 is not the answer, and then you had to use a little more of your concepts to understand that all 3 here in this clinical context context would go in favor of making the diagnosis of ectopic pregnancy. So yes, we have got all the, all of you had attempted it correctly. And Twilight of Apprentice is mentioning color Doppler. Yes. Yes. So when you want to see vascularity of a tissue, you need color Doppler for that. All your gynae ultrasounds, when the zoologist is doing the ultrasound, they first start with the grayscale ultrasound, and when they want to see the vascularity, they will add color Doppler to it, right? Okay. Now, Panda, interesting, Panda Hip Hop. You have a question. I have a question on anemia. We'll come to that question that you have asked a little bit later. Let's look at the next question. 28-year-old woman with 1.5 month period of amenorrhea brought to emergency with vaginal bleeding and crampy lower abdominal pain. They're asking you the likely diagnosis. The options that you have to choose from is threatened abortion, inevitable, missed, and cervical ectopic, right? So, clinical profile of early pregnancy bleeding, let's say, right? Vaginal bleeding seems like the predominant complaint, considering that you can see here that the pulse rate is 110 BPs, 100/76, so she has tachycardia. There is lower abdominal tenderness on palpation. Pelvic examination shows bleeding from dilated os, and the uterus is 6 weeks in size, right? TVS shows a gestational sac in the cervical canal with sliding sign positive. What is the likely diagnosis? So what do we say to this? Yes, most of you, Sayani, Dhriti, Shushtairi, Naina, Pralay, everybody, and those, yeah. So everybody is agreeing that it is inevitable abortion. There's only one, Harish, who's saying it's option number C, but that's okay. See, okay. So I'll tell you why it is not C. Okay, it's not threatened abortion anymore. Bleeding is more, right? In a threatened abortion, there has to be the embryo or fetus. The embryo or fetus has to be inside with cardiac activity present. The os is also closed, and the bleeding is also mild. So it is just the threat of abortion. Here it is a dilated os. The os has started to open up. So it is not threatened abortion. I will eliminate that diagnosis. What is missed abortion? Missed abortion meaning that there is a dead retained embryo inside or a dead retained fetus inside, and the process of expulsion has not started at all, and it may have been retained for a variable length of time, meaning that for quite some time now, maybe days, maybe weeks, the pregnancy inside has not been growing at all, right? So missed abortion is something that we will call as early pregnancy loss, right? So with missed abortion, the patient is either asymptomatic or maybe mildly symptomatic. Like, she may complain of some bleeding, maybe some brownish discharge, but the process of abortion, the process of spontaneous expulsion of the fetus has not started, right? So here, the process of expulsion has started. It is not like, I mean, you may say that there's a gestational sac in the cervical canal, so why is it not missed abortion? It's not missed abortion because the profile is different, right? The process of expulsion has already started. So here it is not missed abortion. You get it now, right? Okay. And missed abortion is picked up in, I'll tell you the clinical contexts in which missed abortion is picked up. So you have a situation where a woman comes to you in the OPD with a dating scan. She's, got a scan done, and she says that, and the report says that there is a gestational sac. Report says that there is a gestational sac inside with mean sac diameter of more than or equal to 25 mm, and it is still empty. That is one possibility. Or there is an embryo inside with CRL that is more than or equal to 7 mm, and yet there is no cardiac activity in that. Right. So this is the diagnosis of missed abortion. Profile different. A scan has been done. Scan may be done for a routine dating scan. Scan has been done for some unrelated complaint or whatever. Right. Or scan has been done just for confirmation of pregnancy or diagnosis of pregnancy, and the scan report has come back like this. So this would be the clinical context that will be set up most of the time. So this is what we call as early pregnancy loss, early pregnancy failure. Very good. Right. Now this is not cervical ectopic. Cervical ectopic is rare. Cervical ectopic presents with painless vaginal bleeding, right? And one could get confused with cervical ectopic in this particular situation, since they mention that the scan shows gestational sac in the cervical canal, but the sliding sign is positive. Now, the sliding sign means that while doing the scan, it was seen that the gestational sac is sliding into the cervical canal. So, I would say it is on its way to expulsion. It was there inside the uterus first, and then it is sliding. It was there, let's say, inside the uterus first, then it is sliding. So, it is on its way to expulsion. It's not firmly, the sac is not firmly attached to the cervix. That is what it's mean, right? So, sliding sign would be positive here. So, answer is inevitable abortion. Right. So, very good, Vamik, you said it's sliding sign positive. In other words, you're describing it very rightly, that shifts from position, right. So, it's not firmly attached to the cervix. That is what it means. So, diagnosis here is inevitable abortion. Excellent. So, most of you got it correct. Now, let's have a look at the next question. So, there comes your anemia related question. This is, I would say this is anemia related question, because this is sort of an integrated question. Most of the times you think about integration in terms of integration between different subjects. Integration also works in between topics. Right. So, this time here we have a 25-year-old primee who's seen in the ANC OPD at 16 weeks, and her hemoglobin is 8 gram per deciliter. We do routinely, HB, don't we check routinely in the first visit itself? So, this one here checked at 16 weeks, 8 gram, peripheral smear shows microcytic hypochromic picture. And when you diagnose anemia, something very basic that you do is, along with that, a peripheral smear. And you also do, you have the RBC indices report with you also most of the times, right? So, they could have mentioned that the peripheral smear is showing microcytic hypochromic picture, or they may have mentioned MCV low. These would have been your clues, right? Now, her HPLC report shows beta thal trait. Her HPLC report shows beta thal trait, right? She is advised all of the following, except what is she not advised? Now, most of you are answering, and Panda Hip Hop, according to your yourself question, you are answering. You mentioned that 10-week pregnant with HB count of 6, best treatment option for her. Iron, folic acid or IV iron. See, parenteral iron, let me write a side note now. Parenteral iron, which we give, and nowadays we are giving IV iron, right? We are giving IV. So, this is IV iron sucrose, or it is either that, or either it is carboxy maltose, right? This is contraindicated in the first trimester. Okay, it is also contraindicated in liver disease, and it will not be used in hemoglobinopathies. It will be contraindicated in case of hemoglobinopathies, those sorts of hemoglobinopathies where your iron stores are not deficient. Okay, because we don't want to overload the iron stores, because that excess iron will also be toxic to the tissues, right? So, you should know here that thalassemia, sickle cell disease, these are hemoglobinopathies where the iron stores are not deficient, right? Therefore, whenever we decide on to give parenteral iron, we have to make sure that our diagnosis is correct. We have to make sure that it is iron deficiency anemia, nothing else, right? Like, for example, in this patient, microcytic hypochromic picture, okay? Now, she could be iron deficiency anemia, or she could, another differential diagnosis is thalassemia trait, right, which in the North Indian belt is particularly very common. All right, fine. So, before we decide whether or not to give our parenteral iron, we have to go for ruling out hemoglobinopathies, right. So, one basic idea is to check the serum ferritin. The other basic idea is to go for the HPLC also. So we will not give parenteral iron therapy here. I mean, I've not even looked at the other options, right? So parenteral iron therapy we will not give. So husband is advised HPLC. Why is husband advised HPLC? Because she is showing alpha thalassemia trait. Now beta thalassemia trait. She's showing beta thalassemia trait. Now beta thalassemia, you know that it is an autosomal recessive disorder, and if the husband is also carrier, then there's a possibility of having a thalassemia child or a thalassemia fetus, right? And the idea is that if we make an early diagnosis of that, then the couple can be counseled for the possibility of medical termination of pregnancy, but only and only if the fetus that the child or the fetus that the woman is carrying is confirmed to be thalassemia. Now that is possible. How? First we'll check the husband's HPLC. If he is carrier, if the husband also tests positive, we do invasive fetal testing. We have the fetal tissue, and then we, make the diagnosis, make a fetal diagnosis, and then we can do that. So this is also advised to the patient. And for her anemia right now, oral iron and folic acid is prescribed. Okay, oral iron and folic acid is prescribed, right? Now, Panda Hip Hop, coming to your question. If in first trimester HB is less than 7, there is no contraindication to using oral iron in the first trimester, right? Also understand here that a lot will depend upon the clinical profile of the patient. In the first trimester, the limitation against using oral iron in therapeutic dosages is that there is anyways a lot of nausea and vomiting, that the woman is experiencing. Now, oral iron also causes gastrointestinal side effects, right? So there is no contraindication to using oral iron, particularly in the first trimester. We generally tend to avoid it. Okay, and other than that, the requirement of iron in the first trimester is anyways very low. Okay, it's not as much as is needed in the majority of the daily requirement of iron in pregnancy is distributed in the second and third trimesters, right? Now, for example, if I have to treat severe anemia in the first trimester, so much so that the woman is getting maybe impending heart failure, or she is in the first trimester she is having bleeding, right, and she's having severe anemia along with that, then I'll go with blood transfusion. So the answer to your question is not straightforward until unless the clinical profile is set. Okay, so in the first trimester, if I'm having severe anemia, I will look at the clinical profile of the patient as to what best needs to be done. It will not be parenteral iron, but it can be oral iron or it can be blood transfusion depending on the situation at hand. Okay, all right. So if less than 7 is not independently an indication of blood transfusion. For blood transfusion in pregnancy, anemia in pregnancy, just maybe writing a short side note here, anemia in pregnancy, indications of blood transfusion. Okay, so blood transfusion is done if she is having HP less than 5 gram per cent and any time, meaning first, second, third trimester, anytime in pregnancy, right? If it is between 5 to 7 gram per cent and she is more than 34 weeks, okay, then also we have to give blood transfusion. Other than that, if there is signs and symptoms of impending heart failure, right, she has some superimposed infection or she has ongoing bleeding, then these would be broadly, I am writing down for you, broadly these would be the indications of blood transfusion in pregnancy. So let HB less than 5, then any time in pregnancy. HB is 5 to 7 and she is also more than 34 weeks, then definitely blood transfusion is needed. All right, and let's say the HB is between 5 to 7, she may be in the first trimester, second trimester or wherever, but she's also having signs and symptoms of impending heart failure. So if she's not fitting into 1, if she's not fitting into 2, then look out for the third choice for blood transfusion indications. Okay, right. Now, I have got a question from Gus. The heart disease in pregnancy, is it, if I don't say your name, no, it means that I'm not able to pronounce it. Now, heart disease in pregnancy, is it important to memorize the WHO criteria? Like you're talking about WHO criteria for WHO criteria, class 1, class 2, class 3, class 4 type of heart diseases. I would say that is too much. Okay, even I don't memorize it by heart. I mean, I don't remember it by heart. But what you do tend to know is where pregnancy is absolutely contraindicated. That would be the good thing to know, right? Okay, like where absolutely it is contraindicated. So broadly speaking, for you answering before I move on to the next question, broadly speaking, let's say for example, when you have Eisenmenger syndrome. So Eisenmenger syndrome is a broad group. Eisenmenger syndrome is a broad group where there is pulmonary hypertension. So that pulmonary hypertension could be secondary. So there could be some ASD, VSD, which is complicated with later on right to left shunt has developed. It becomes Eisenmenger, or it is primary pulmonary artery hypertension. The idea is that a woman is anyway cyanotic and her hematocrit is raised. She can't even oxygenate herself. How is she going to oxygenate herself and the fetus for the remainder of the pregnancy? Very high risk. So what did I understand? I understood the logic, and then I understood that Eisenmenger and those conditions where Eisenmenger is, whether it is secondary pulmonary hypertension or primary pulmonary hypertension, pregnancy is absolutely contraindicated. So in other situations where the patient cannot increase her cardiac output at all in pregnancy, and that will put a dramatic load on her heart, right? Because in pregnancy, the cardiac output has to increase. Now, if she cannot increase her cardiac output, it will cause heart failure because it will cause back pressure changes then, right? So if you have severe MS, if you have severe aortic stenosis, severe mitral stenosis, pregnancy is contraindicated, isn't it? So remember by logic. I would say that would be more important. And let's say, for example, she is already breathless at rest because of her heart disease, whatever her heart disease. So NYHA class 3, class 4, pregnancy is contraindicated. Already her ejection fraction is low, pregnancy is contraindicated. You would say ejection fraction less than 30%, 30 to 40%, pregnancy would be contraindicated. So I don't mug up the entire WHO criteria, but I keep my eye open for situations where pregnancy is very high risk, pregnancy is preferably contraindicated, and in case the woman does get pregnant, I would counsel her against keeping the pregnancy and counsel her towards MTP. Okay, so that is the idea. Now, let's have a look at the next question. So, Jayashri, I think that answered your question. Okay. 28-year-old woman has come for, yes, and Butterfly has added 2 more to the list, Marfan and coarctation of aorta, especially when the aortic root is dilated. Think about it, aortic root dilated, yeah, aortic root dilated more than 40 mm is the criteria now to add to it. So when the aortic root is dilated so much, think about all that increased blood flow across the aorta that is happening, and on top of that cardiac output is increasing, and during labor she will need to bear down, then further it will put an extra load on the heart, that dilated aorta may burst, and then she will end up with an aortic aneurysm. So it becomes a very life-threatening situation then. So obviously pregnancy will be very high risk for these sort of women. So they have already mentioned that the diagnosis of antiphospholipid antibody syndrome has been made, but she's come for preconceptional counseling. She has 2 prior spontaneous abortion, one at 10 and another at 15 weeks. Each time ultrasound had shown cardiac activity in the fetus. Now, I've written the stem, I've kind of twisted the stem a little bit because I think this was a recent FMG question. I've added to the stem of the question so we could have this discussion, right? Now, 2 prior spontaneous abortions, one at 10 and another at 15 weeks of gestation. So, yes, for the clinical criteria of antiphospholipid antibody syndrome, even one pregnancy loss of a morphologically normal fetus beyond 10 weeks of gestation qualifies as a clinical criteria. But most of the times in clinical practice, what happens is the investigation or workup of the patient begins after 2 pregnancy losses. We start investigating for the possibility of APLA or testing APLA if, in such women when there are, when she qualifies the criteria for investigation, like she has 2, pregnancy losses. So So if you look at this situation here, that will give you an idea about under what circumstances APLA is diagnosed. Okay, so remember this clinical profile. So she has 2 spontaneous abortion, one at 10, another at 15. Each time USG had shown cardiac activity in the fetus. So most of the times, even with recurrent pregnancy loss, okay, even with recurrent pregnancy loss, most of the times, the cause of such pregnancy losses is actually chromosomal abnormality in the embryo itself. If it is showing cardiac activity in the fetus each time that those pregnancy losses happened, it is also pointing towards the possibility of, there is a possibility of euploid pregnancy losses. Because each time in those pregnancy losses, cardiac activity had come. If there was an aneuploid embryo that was aborting in previously, then cardiac activity wouldn't have come, most likely. Now, in her last pregnancy, she also had induced preterm delivery at 28 weeks in view of severe preeclampsia. Now, this also adds to the clinical diagnosis of APLA. And of course, it must have been confirmed by the lab criteria. That was not mentioned in the clinical stem. But of course, it needs to be confirmed. You need to have one clinical, one lab criteria. Now, what is the most appropriate preconceptual management strategy? So, students had gotten confused in this question regarding whether she was already pregnant or whether she was coming for preconceptional counseling. Now, I'll give you the answer here. If the preconceptual management strategy for this patient would be low dose aspirin alone. Low dose aspirin alone. So, aspirin can be started preconceptionally. Aspirin can be started preconceptionally, and low molecular weight heparin is added as and when the woman is diagnosed with pregnancy, right? So, when her UPT comes positive, from that time onwards, low molecular weight heparin is added once the urine pregnancy comes back positive, right? So, not alone, none of the above is not the answer, and low dose aspirin alone would be the best choice answer, considering she has come for preconceptional counseling for this particular patient. Now, there was a question, we are still stuck on heart disease. Where was that question? I forget, it's just, it kind of went away. Okay, now I have Panda Hip Hop answering, isn't the latest ACR Euler criteria says more than one pregnancy loss, more than 16 weeks of criteria for APLA? See, the latest ACR Euler criteria is for, there is a lot of, I would not say word discrepancy, there is a lot of, what do we say? How much of that Euler criteria is applicable to the gynae patients that we see is a matter of concern, because with that Euler criteria, if we use it very strictly, most of our women would not qualify for the diagnosis of APLA. Okay. So again, there is this discrepancy between what the European, that is ESHRE guidelines, or even the latest ASRM says regarding the use of Euler criteria. They have mentioned it, but I would say still the diagnosis of APLA in the context of recurrent pregnancy loss. The Euler criteria is from rheumatology. So, they are making the diagnosis of APLA, and they have given the criteria for APLA, saying that those women who are having recurrent pregnancy losses, okay, if we start using that criteria, most of the women will not qualify and they will not get the treatment. So, we are not sure if we are using that in clinical practice as of yet. Okay, so that is what I have to say to that. Yes, 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 Panda Hip Hop. So what happens is that what happens, Panda, is that that I would not ask from the gynae perspective or from the ops perspective. I will not ask you I will not ask you a question on the criteria particularly. I will give you a profile where most likely it will fit into APLA. That is what I will do if I were the examiner. Okay. All right. And it's Soporos criteria. Next question. All right, a 32-year-old woman who has been a known diabetic for 7 years presents with a history of mixed periods and a positive home-based pregnancy test. She is anxious about her diabetes adversely affecting her baby. Which of the following would be the most helpful investigation to identify the risk of fetal malformation? Now again, see, I am seeing a trend towards they asking questions on preconception management, like optimizing the patient status before pregnancy. And preconception counseling is a place where a lot of integration ka scope is there. Why? Because you have a woman, young reproductive age group female wanting to get pregnant. She may be having this disease, that medical condition, this medical condition, some bad obstetric history. And then you have to integrate all that and give her the most appropriate advice. Like we saw, what if she is a known case of thalassemia trait? Okay, she is planning to get pregnant. Okay, so like that, they could frame a question. Or what if she is a known case of sickle cell disease and she is planning to get pregnant? So a lot of scope is there of integrating such situation. Known case of heart disease, planning to get pregnant. Similarly here, known case of diabetes, planning to get pregnant. So investigation which will identify the risk of fetal malformation, right? Now see here, those of you who are saying option A is the correct answer. She has come for counseling. She has a positive home pregnancy test. Okay, that means she is just UPT, she's just tested positive. Okay, she's a known case, she's just tested positive for pregnancy. She just has a history of missed periods. Okay, so what would be the most helpful investigation to identify the risk of fetal malformation is glycosylated HB, because that will tell me about the level of control she has had in the periconception period. This would give me an idea about the periconceptional control, periconceptional blood sugar levels. Okay. Fine. And then I would be able to counsel her better regarding what is the risk of fetal malformation in this woman. So, if a periconceptual blood sugar levels are controlled, so ideally the HbA1c that I want should be less than 6.5%. Right, and Pallavi is adding more percentages to it. HbA1c, and very rightly so, HbA1c more than 10%, very high risk. Yes, to the tune of 15 to 20% risk. You're correct in that range, right? Now, why not C in the option? C is not telling you about the risk of fetal malformation. First trimester combined screening is anyways routinely we are offering to pregnant women. We will offer to her also. And this combined screening is for aneuploidy. It is not for the risk of fetal congenital malformations. Please understand, congenital malformations are different. Gross congenital anomalies like cardiac defects, like renal defects or whatever, or like neural tube defects. Structural malformations, those are fetal malformations, and aneuploidy is completely different. Down syndrome, trisomy 18, 13, monosomy X, right? So those are aneuploidy. So your these first trimester combined screening or your quadruple screening, they give you a combined possibility risk of, we call it prenatal, prenatal and aneuploidy screening, right? So this will not give you the idea or the risk of fetal malformation. Targeted sonography will be done anyways, it is routine, will be done as and when the time comes, right? Like for example, if her HbA1c is particularly high, I can counsel her about the risk of fetal malformation, but that itself will not be an indication for termination of pregnancy. But then yes, this patient becomes one in which I want to achieve better control of sugars faster, so that in the first trimester we maintain, we try to achieve blood sugar control faster in case she has excessively raised HbA1c levels, right? So targeted sonography we will do as and when the time comes, and fetal echo will also be justified in these women, isn't it? So fetal echo as and when the time comes, because, and fetal echo timing is somewhere between 22 to 24 weeks to look for cardiac malformations. Cardiac malformations are anyways the most common malformations that we encounter in fetuses of diabetic mothers, right? So Ayushi, gestational diabetes never causes malformation. No, it is not causing, it is not associated with congenital malformations. No. not gestational diabetes, it is this, right? So ideally, please remember here, ideally, let's talk about ideally HbA1c should be less than 6.5%. Ideally, this patient should be seen preconceptionally. Ideally, such patients should be seen preconceptionally, so that whatever dosage adjustments, drug adjustments have to be done, they are done pre-pregnancy, right? So for a woman who is trying to conceive, ideally she should be put on insulin for better sugar control. That is ideal, right? And ideally she should be off oral hypoglycemic agents, but metformin is safe and she could continue metformin. So if there is a diabetic patient, if there is a diabetic woman, she is on metformin, that is her on that she is controlled, she could control her, she could continue with the metformin. If she is on oral hypoglycemic agents, then ideally, again preconceptually she should be switched over to insulin, safer insulin, right? Fine. Now let's have a look at the next question. So in this question, now partogram based questions can also be asked in your exam. Let's see here. A 32-year-old primey at term was admitted in active labor. Analyze her partogram and suggest the most appropriate next step in her management. Yes. Right. Now, the whole idea about attempting these clinical questions is to look at keywords or to look at key findings and attempt them quickly, because again, time is of the essence, right? So, the choices given to you are oxytocin, urgent cesarean, allow bearing down and instrumental vaginal delivery. So, broadly if you look at it, you get an idea that the fetal heart rate is on the lower side. What do you get an idea? That the fetal heart rate is 110 beats per minute. Okay. I would say, let's say focus on this part of the graph here, right? So, you see that initially the partogram plotting started when she was 5 centimeter here, then it progressed, but it was slow progress in the next 4 hours, and she has managed to reach 10 centimeter dilatation. And this is where it gets interesting. For 2 hours now, she has been she has not delivered as of yet, and now she is having molding here. So here meconium and molding, that is your biggest clue. Meconium and molding, that is your biggest clue. And you can see that the descent has also arrested, and the head is high. It is 2/5 palpable above pelvic brim, 2/5 palpable above pelvic brim. So the moment that you see this, okay, the moment that you see molding plus 2/5 palpable above pelvic brim, she has managed to be fully dilated, but 2 hours have gone by with good contractions. Right, the contractions are completely shaded, 5 boxes are completely shaded. These are good contractions for 2 hours. Now, allowing bearing down for 1 more hour is not going to be an alternative, because already molding is there, already fetal heart rate is on the lower side. So, it does not make sense, right? Oxytocin augmentation makes no sense because she is already getting good contractions. And instrumental vaginal delivery, you will not attempt, the head is high up, right? So, for instrumental vaginal delivery, you need to have no evidence of CPD. There should be no molding, no grade 3 molding at least should not be there. So, no evidence of CPD should be there, and the head should be at +2 station and beyond, and this is 2/5 palpable above the pelvic brim. Descent has gotten stuck. So, this is absolutely out. So, your answer is urgent cesarean section, right? So, Tamil Maran, 110 is okay, 110 is just very borderline. Less than 110, if the baseline fetal heart rate is, we call it as bradycardia. So, this is just borderline. In the second stage, we do find fetal heart rates in 100-110 range mein aate hain second stage mein fetal heart rate, but again we need to be cautious. So, the decision is never made on a single factor alone until unless there is sudden severe bradycardia where fetal heart rate is not picking up. Most of the times clinical decisions are based on the entire clinical profile of the patient rather than one. Right now, वैक्यूम 0 स्टेशन पे लगा सकते हैं, करने को कुछ भी कर सकते हैं, लेकिन आपके लेवल पे +2 एंड बियॉन्ड इज द इंस्ट्रूमेंटेशन. हम नहीं लगाते. +1 पे नहीं लगाते, वैक्यूम हो चाहे forceps, so we do not use instruments. So again, practices differ across countries, across labor rooms, right? So some people may be very expert, they may be putting vacuum at, they may be putting mid cavity forceps also, but we are doing low forceps application and vacuum also +2 station and beyond. Okay, so that's it. Instrumental vaginal delivery +2 station and beyond. Let's have a look at the next question. Now see, look at this question. A low-risk primee at term was admitted in active labor in cephalic presentation. She's been in the second stage for 2 hours. Context is set. Second stage, 2 hours. Okay, so it's getting prolonged now, and there is fetal bradycardia. So obviously there is an urgency to deliver. She's getting 4 contractions in 10 minutes, each lasting for 50 seconds. What do I get an idea? These contractions are adequate contractions. These contractions are adequate. These contractions are good, right? Head at +3 station, sutures AP diameter, caput but no molding. Caput but no molding. What is the most appropriate next step? Of course, I just told you that we are not doing mid cavity forceps, right? So now the trick, yes, is it ventouse, is it outlet forceps, or is it low forceps? Yes. So most of you are answering correctly. Tamil, you're still saying option number A as the answer. See, actually, to be very frank, ventouse or outlet forceps. So first of all, it is not going, I will not use low forceps. I will not call this kind of forceps application as low forceps application. It's forceps application is defined as outlet or low forceps application. It's not the forceps design per se, right? So when I apply forceps at station +2, it is low forceps application, right? Outlet forceps application is when I apply forceps, at that moment the head is on the perineum. Head is on the perineum, the scalp is visible at the introitus, scalp is visible at the introitus, right? So fetal head at +3 station, fetal head at +3 station is telling me that head must be on the perineum, right? So that is what it means, okay? Now I have to choose between ventouse versus outlets. I could use either. I could use either, actually I could use either, but just for preference. It's not like ventouse cannot be applied here. They can be applied here, but I will prefer outlet forceps because of the caput, because of the caput. Okay, when there is a caput, it becomes very difficult to place the vacuum correctly. It becomes difficult for the suction pressure to be raised adequately. The chances of vacuum pop-off also increase. That is what is the clinical judgment we are talking about. So the answer to this question is solely based on clinical judgment. It's not like ventouse आप लगा ही नहीं सकते. Supposing you know only ventouse, somebody knows only ventouse, would use only ventouse instead of using forceps that he doesn't know how to apply. Right. So much of the times it is also about operator expertise. But considering given 4 choices in examination, the better choice answer would be outlet forceps. Because of the caput, and also considering the fact that there is fetal bradycardia, the forceps applied and all the traction is applied by the examiner and we achieve a quick delivery. That's the basic idea. Right. Now, asparagus, vacuum contraindicated in fetal distress. Vacuum is not contraindicated in fetal distress. Okay. Please understand, vacuum is not contraindicated in fetal distress. There was a time when we had metallic cups, उसमें होता था, when we had used to, that was in my PG times, okay, we used to have metallic cups, उसमें we used to raise the pressure very slowly, 0.2 kg per meter square, धीमे करके we used to, raise the pressure to 0.8 finally, and that would take time. So the idea was that ventouse takes too much time, and when there is sudden fetal distress, I want quick delivery, so I will use forceps. But now with this elastic cups or with the Kiwi Omni cups that we have, we can quickly raise the pressure. So it is not like vacuums are contraindicated in fetal distress. The statement, blanket statement, is not correct anymore. Okay. Clear? Ventouse are definitely contraindicated in prematurity. Ventouse are definitely contraindicated in face presentations. Understand? And are you dead fetuses? Because understand that, you can't apply suction on the face or on a premature soft head, right? Okay, clear? All right, so panda hip hop, vacuum have more fetal complications. So in fetal bradycardia, we should not use. No, the idea why we were not using in fetal bradycardia, some you may have gotten it from maybe older textbooks or from some older practices. So a vacuum we were not using in fetal distress. The idea was that it takes time to increase the pressure. So वो time waste होता है. That was the idea. Okay, correctly applied vacuum से फिर क्या fetal complications का क्या मतलब है, right? Okay. Now, Dr. Nihad, how will we differentiate between Keelans, Wrigley's, Pipers, etc.? Now, though I cannot answer that question, bache, without the images here. This is not an image-based session. Image-based session we are having. Upcoming, we are having image-based sessions also. Image and video-based sessions. So, we'll discuss that there. Next question. Now, let's look at this question. Most appropriate management. Okay. And I can give you permutation combinations of scenarios, but what you have to understand is you will answer according to the clinical patient's profile. Okay, so let's see. Most appropriate management, I have to choose between urgent cesarean section, oxytocin, forceps, vacuum. The idea is get a hang of what they are asking so that when you read the question, you know what to look for, right? Like for example, urgent cesarean, is there an indication where I will need to deliver right now? Oxytocin, do I still have time to increase contractions? Are the contractions inadequate? Then I will use oxytocin. Forceps, vacuum. Is the criteria for instrumentation being fulfilled so that I can use that, right? So when you read through the options also, you get a hang of how you are going to read the question and what keywords you should be looking for in the question. Now in this question, 26-year-old G2P1L1 previous cesarean, right? Profile said clean, previous cesarean, at term active labor, tachycardia in the mother, BP is fine, getting good contractions. Now if she is already getting good contractions, giving another round of oxytocin augmentation will do no good, right? Right. And also she is previous cesarean section. So in previous cesarean patients, I also have to be all the more cautious. कि भाई इनमें if I go for excessive contractions, the scar may rupture. So oxytocin, no, I will not choose that answer. CTG shows baseline fetal heart rate at 120, persistent late deceleration. Now what is this telling you? What is this telling you? A woman with previous cesarean section in labor and persistent late decelerations, and the rest of the everything is all just building on the clinical profile. But just this one finding is telling me something, that the possibility of scar giving away is there. I'm not saying I'm 100% sure, but the earliest, most because you know maternal tachycardia can be very non-specific. Tachycardia can be because of dehydration, bleeding and everything, and so like that. And your scar tenderness that we see on perabdominal examination, very non-specific. But in a woman with previous cesarean section, in labor, having persistent abnormal fetal heart rate patterns, okay, any abnormal fetal heart rate patterns like you know this. So this is now telling me not just uteroplacental insufficiency. See. When you see late decelerations, all you think about is uteroplacental insufficiency. But in the clinical context of previous cesarean section, itne sare I am giving you hints. Even then you are not coming up with the answer. It is possibility of impending scar rupture. Okay, you know what this question tests? This question tests whether you have actually possibly ever seen a previous cesarean section patient being monitored in the labor room. This question tests that, because if you have, then you would know how cautious we are with these women. Previous cesarean section in labor, they deserve, whether they do get in our labor room, that's another matter, but they deserve continuous cardiotocography monitoring because of impending scar rupture and our earliest clue. इसके beyond तो फिर rupture ही हो जाएगा. Okay, when she'll start having excessive vaginal bleeding, when she'll start getting decompensated, when the fetal distress, when the fetal heart rate will disappear, that is too late, right? So this is your first clue. This is your first clue. Okay, so this is your first clue. Now, PV shows the cervix is fully dilated, effaced, vertexes +1, sutures, LOA, membranes absent, like a meconium stain. All those are additional findings. But your biggest keyword was persistent late decelerations, previous cesarean section. Which of the following is the most appropriate management? No wasting of time. I will do urgent cesarean section for this particular patient. Now, when this question was recalled in the previous examination, students were confused. What was the station given? Students were confused. What was the station given? Was it +1? Was it -1? Was it 0? Was it +2? I said it doesn't matter what it was. However, yes, if this is the stem +1 station, if this is +1 station, then that eliminates this absolutely. Okay, because high station, we cannot use instrumental vaginal delivery. So, +1 I cannot use. Even if this patient had +2 station, I would not go for instrumentation in this particular patient. Possibility of scar rupture is there. I would have even then gone for urgent cesarean section. Okay, clear? Yes. So, my best choice answer is urgent cesarean section. Right, and you can write then here on the side, earliest, most definitive sign is FHR abnormalities on CTG, which evolve. Fetal heart rate doesn't disappear like that. Okay, they evolve. So, initially there is fetal tachycardia. Initially, I may find fetal tachycardia. Then it evolves to decelerations, variable and late decelerations that are persisting. Okay, then it evolves, then finally bradycardia. So, it evolves. These abnormality evolve over time into this pattern. Okay. Now, let's have a look at next question. Now, this question has come with the CTG strip. Okay, a primary gravida is undergoing induction, and again, if you don't, now this question is similar to this question was asked in recent PYQ, but I have been discussing these clinical concepts with you in most of my lectures also. So, let's see if you can attempt it. Okay, so that is why I like this idea that this is the PYQ challenge. Okay, you people have already studied, already read up hopefully for your upcoming NEET PG examination, and now you challenge yourself with different questions. So, let's see. इम्पेंडिंग रप्चर में इंस्ट्रूमेंट्स लगाएंगे ही नहीं क्या? नहीं, मैं तो नहीं लगाऊंगी. I will not. No. If a question asks everything impending scar rupture, you will go for no. For impending scar rupture, if I'm writing the diagnosis on the case sheet of the patient, impending scar rupture, I would like to take her up for cesarean section immediately, because then I will end up, what will I do? I will forcefully deliver the baby from down below, maybe apply instruments, जो rupture impending था उसको और मैंने rupture कर दिया, and then deal with the consequences. What is this? No, we don't do this kind of nonsense practice clinically. नहीं, it doesn't make sense ना. हमारा एक ही आइडिया होता है ऑब्स्टेट्रिक्स में, नो व्हाट नॉट टू डू. ओके, यस. सो नाउ आई कैन सी योर रिस्पॉन्सेस. BBB ARM. अच्छा, अभी देखो जो ARM कहा ना, हाउ आई विल डिस्कस. लेट्स डिस्कस. So, a primary is undergoing induction of labor at 38 weeks with fetal growth restriction. You observe the following non-reassuring pattern on CTG trace as shown. So, what do we see in this CTG trace? We see these, V-shaped decelerations, V-shaped, or they may be this W-shaped or V-shaped deceleration. So, remember the shape because they drop very fast. So, these are variable decelerations. Right? And they can come with contraction, before contraction, after contraction. So, in that sense, they are not related to contraction. That means like early decelerations, they come with contractions only. Right? So, early deceleration would be something like this. Somebody was asking me how to differentiate. So, you will look at the contraction trace. Early deceleration will be an exact mirror image, and it will be like a cup. Okay, the fetal heart rate drops slowly. Okay, and as the this is contraction, this is fetal heart rate. As the contraction is peaking, the fetal heart rate is lowest, and by the time the contraction is over, fetal heart rate has normalized. This is early deceleration. And late deceleration would be contraction is here and late deceleration is here. Okay, so you will see a specific pattern to it, in the sense that by the time when the contraction is peaking, that is the time when fetal heart rate starts dropping, and by the time the contraction is over, fetal heart rate is still low, it has not yet recovered, and it will be like a cup instead of like a V shape, it will be like a cup. Okay, so this is late deceleration, this is late deceleration, uteroplacental insufficiency and fetal hypoxia and all that, right? Variable deceleration is because of cord compression, right? Now, if there is a deceleration because of cord compression, yes, and it is generally, the idea is that whenever an abnormal fetal heart rate pattern is discovered, you have to see that, okay, you know, maybe she's having hypotension, or is she dehydrated, you know, or is she losing blood. So, understand here that uteroplacental insufficiency is being caused by less placental perfusion. That is what it means. No, uteroplacental insufficiency means less placental perfusion. So, in situations where there are excessive uterine contractions, in situations where there is maternal hypotension, right, there will be uteroplacental insufficiency, and there can be late decelerations on the CTG also. So, clinical context matters, right? So, whenever, so we tell our, so what do we tell our undergraduate students, let's say, who are monitoring the patients here and there? They should be able to identify the abnormality, and they should be able to take the immediate resuscitative measures till the time of how we will deliver, or whether we need to deliver immediately till the time that question is answered, right? So, maternal hypotension, hypotension could be in the context of maternal dehydration. She may be lying down supine for a long duration of time, so she could be supine hypotensive. She could be dehydration because they're dehydrated, that is why hypotensive, or she could be bleeding, that is why hypotensive, and that is why late decelerations on CTG have started to come, or she may be getting excessive uterine contractions, right? So, yes, what we need to do, we need to put in the resuscitative measures which will help the oxygenation of the baby, and which will help in relieving any cord compression if that is taking place. So, that is why shifting the patient to supine position is completely out. You have to shift the patient to left lateral position. That is something that you will do. Okay, that is something that you will do. Now, for those of you who are saying Trendelenburg or knee chest or reverse Trendelenburg, cord prolapse हुआ कहाँ है अभी? Does the question in any way say that there is cord prolapse? Right now, you are at the patient's bedside, all you are seeing is an abnormal CTG, all that is telling you is cord compression, right? Fetal growth restriction is also there, maybe she has oligo also. Right, maybe that is the reason why she is getting cord compressions in labor, that could be the reason, right? So, abhi for now I don't know whether there is cord prolapse. There could be cord presentation, or there can be an impending cord prolapse may be there because she is in labor, maybe the cord is getting compressed here alongside, or it is a cord presentation. That information I don't know as of yet. When I will do a PV, then I will know. That is why also it is very important, whenever we have fetal distress, we do PV, right? So, I don't know that information as of yet. So, I will say shift to left lateral position. So, at an undergraduate level, I don't expect undergraduates to do this PV for me. So, you will call your senior, you will shift to left lateral position. You will stop the oxytocin infusion if it is ongoing. That is something that you will do, because excessive uterine contractions can also lead to uteroplacental insufficiency. Supposing there is oligohydroamnios, cord is getting compressed, variable decelerations are happening, what will happen if the contractions will increase? The chances of cord compression also increase when, you know, contractions are ongoing. So, that is why stop oxytocin infusion. That is something that you need to do, because that could be the reason here why this cord is, maybe there is excessive uterine contractions. That is why, you know, cord compression is also probably happening. If you perform an immediate ARM at your level, you know, without even taking into, you may do an ARM. Yes, I may do an ARM. Okay, you will do a PV, make sure that there is no cord presentation. All right. And then yes, safely we can do an ARM. We can do an ARM, but that is not the priority right now. Priority is to stop the oxytocin infusion. Before performing ARM, one also has to ensure that there is no cord lying nearby and the head is fixed. With a high head, I will probably avoid when so there are many things. One thing leads to the other. So for now, I will not perform an immediate ARM as the best choice answer. It will not be there. Maybe yes, once further assessment is done, per abdomen examination is checked, the head is fixed, PV is done, there is enough dilatation to safely do an ARM, head is fixed, right, and your cord is not lying nearby, we ensure that. So then of course we can do an ARM. So that will happen next, and then yes, of course later it will come whether you want to do an immediate emergency cesarean section. Whether or not we do a cesarean section will depend upon whether these abnormal fetal heart rate patterns persist, what is the PV finding, what are the additional patient characteristics, right. So for now the best answer to choose is option number B. So what I tend to see is that when they are asking you maybe clinical questions based on CTG, as an examiner, if I were to think like an examiner, like, you know, when we ask our undergraduate students that we teach, we are mostly asking them about the initial resuscitative steps, because that is what is expected out of you people, not complex decisions in obstetrics, but the basic decisions in obstetrics, right? So keep that in mind. राइट. सो ध्रुव पटेल, फीटल हाइपोक्सिया कितना है उस पर डिपेंड करेगा. वो डिपेंड करता है, जैसे फॉर एग्जांपल आपका ये परसिस्टेंट वेरिएबल डेसलरेशंस है, इनमें एटिपिकल फीचर्स भी आ गए. देन यू हैव दीज एब्सेंट वेरिएबिलिटी आल्सो कम्स, और देयर इज परसिस्टेंट ब्रेडिकार्डिया विद एब्सेंट वेरिएबिलिटी. सो टू mug up a list, that is different. But please, let's be wise enough here that either I will give you such scenarios where it is pretty obvious that she has to have a delivery, where I will mention bradycardia, why, right? So clinical questions from this area will not be on gray zones. At least keep that in mind. So do not bother about that, is my advice to you. राइट. सो यू आर राइट हियर दैट ध्रुव पटेल के फीटल हाइपोक्सिया कितना है वो कैसे पता चलेगा. वो ऐसे पता चलेगा, देयर मे बी सम कैरेक्टरिस्टिक, मे बी द फीटल ब्रैडिकार्डिया इज देयर एंड इट इज नॉट पिकिंग अप, or there is fetal bradycardia in the context, clinical context of placental abruption is there. तो वो अगर उसको, if I have to frame a clinical question, then I will have to give you a clinical scenario where it will be pretty obvious that she needs to deliver immediately. Okay, get that? Ayushi, since she's already at term, can't we go for cesarean section now? The question was, what is your immediate course of action after informing your senior? By the time your senior comes, examines the patient, decides what to do, what was your immediate course of action? Okay. So priority was to stop the oxytocin infusion. She was undergoing induction of labor. Okay. And if you look at this, these were the contractions that were coming very frequently. Okay. Fine. Now, sinusoidal decelerations we see in the context of severe fetal anemia, sudden severe fetal anemia or severe fetal hypoxia. So, if you look at Anjali's sinusoidal would be sudden fetal anemia. So, in the context of bleeding vasa previa, maybe sudden intracerebral bleed in the fetus. So, sudden fetal anemia developing in the context of twin-to-twin transfusion syndrome. So, think of all those conditions where you can think of sudden fetal anemia developing. Okay. Next question. Unbooked multiparous 9-month gestation in labor in emergency in collapse state. On examination, the fetal parts are superficially palpable. Fetal heart sound cannot be heard. 5 centimeter dilated. Presenting part cannot be felt on PV. Bright red vaginal bleeding, most likely diagnosis. Yes. Ayushi, they will not ask you to, Ayushi, they will not ask you senior doctor ka question. They will ask you, you are the person. Why will they ask you when you are not the senior doctor? That's such kind of question I've never seen. Secondly, C-section, if I wanted to frame a question on C-section, I would change the stem of the question, right? I would say that resuscitative measures were taken and the fetal heart rate is not improving, or there is sudden bradycardia, fetal heart rate is not picking up. Okay, then maybe I would have given you that scenario. And when there is fetal distress, please understand, fetal distress by itself doesn't mean cesarean section. Now that you mentioned, prepare for emergency cesarean section. What if she is fully dilated, qualifying the criteria for vacuum or instrumental vaginal delivery? Then the quicker way to deliver would be by instrumental vaginal delivery. How do I know that it has to be a cesarean section? Whether or not one has to, when there is fetal distress, idea is to deliver fast. Deliver. How deliver? Can we still deliver vaginally, or it has to be a cesarean section? Will depend upon where in labor is she. Is she fully dilated? Is the criteria for instrumental delivery fulfilled? Then you go for instrumental delivery. Otherwise, यहाँ पे भी हम कई जगह पे cesarean ही कर देते फिर हर किसी का. Understood ना? Yes, Ayushi. Now, why not emergency cesarean section was the best choice answer. So yes. What is the answer to this question? There's bright red vaginal bleeding, most likely diagnosis. So, answer is A, yes, rupture uterus, considering that there is no other situation where you will see superficially palpable fetal parts, right? There is no other situation where you will see superficially palpable fetal parts. So, that has to be rupture uterus. Considering you look at the risk factors, she is grand multiparous, she is come in the collapse state unbooked also, and fetal heart rate is also. So, of course, when rupture uterus happens, then that can cause fetal death also. And presenting part cannot be felt on PV. That is your another keyword. Presenting part not felt on PV, meaning this is what we call as loss of fetal loss of station. Okay. If presenting part is not felt on PV, that means rupture must have happened and the baby has been expelled into the peritoneal cavity. That is what it means. Okay. So, that is why most likely answer rupture uterus. It is not an abdominal pregnancy, because again in abdominal pregnancy also superficially palpable fetal parts are there, but again it is a rare situation, and in this patient she is ongoing in labor, 5 centimeter dilated, you know, so it does not fit into the abdominal pregnancy criteria also. And abruption, it is not isolated abruption anymore. See, what happens is when the baby, let's say this is the uterus, let's say this is where rupture took place, okay, and this was the baby earlier here, and now rupture took place. So, the baby has been thrown out or delivered here into the abdominal cavity, right. So, what you tend to see on per abdominal examination is this is the superficially palpable fetal parts. Okay, there was this umbilical cord here and it was attached, placenta was attached. What do you think will happen once it's sort of like baby has been delivered into the peritoneal cavity. After this, the placenta also detaches. Okay. So, yes, the placenta detaches and that is what causes this fetal death. Okay. So, it is not isolated abruption right now, this is rupture uterus, and this is not placenta previa where we have painless causeless bleeding. Right. Now, I will show you the context where you will have, I will show you the clinical context where abruption will be your answer. Okay. All right. You think I will not have question on abruption? I will have question on abruption also. Let's first go to this question. No, abruption bleeding will not be painless and causeless. It is very unlikely that abruption bleeding will be painless. Abruption patient may not have bleeding obvious because it may all be concealed, but pain is definitely there. Okay. Fine. Now, during active management of third stage of labor, immediately after delivery of baby, which intervention is recommended to prevent postpartum hemorrhage, right? So, early cord clamping is definitely not an intervention. Remember, it is delayed cord clamping, 1 to 3 minute delay is there for all vigorous babies irrespective of their birth weight. Oxytocin is the one drug that is the drug of choice. Remember, 10 units IM or slow IV immediately after delivery of the baby. This is the drug of choice. The second drug that we can use is heat stable carbetocin. Okay, and the third drug that we can use is misoprostol. But please remember, methergin is something that we have never used in our labor room, and WHO also recently said that it is not to be used. With methergin, there can be retained placenta. Now, controlled cord traction is also a method which we use for delivery of the placenta in the third stage of labor. But for somebody who has already received oxytocin, you see, please understand that controlled cord traction is not the main component. The main component is use of uterotonic drugs. Alright, so keep that in mind. That's why C is not the best choice answer. And fundal massage is something, again, for somebody who has received this oxytocin, somebody who has received the uterotonic, doing this fundal massage, if you do, there's no harm in doing, but it is unnecessary. It is not required. WHO does not recommend vigorous fundal massage in the third stage. Okay, just mentions that, okay, intermittent uterine tone assessment, that we keep continuing in the fourth stage of labor. Okay. Fine. Now, let's have a look at the next question. Let's have a look at the next question. A 26-year-old primee has just delivered vaginally. During attempted delivery of placenta, cord traction is applied and immediately becomes profoundly hypotensive and tachycardic, right? So, when you read through the context, you see that something happened. See, cord traction is applied and she immediately becomes profoundly hypotensive and tachycardic, right? So, hemodynamic instability when cord traction was applied. So, this is third stage mismanagement, that is your keyword. The whole point is, bache, the whole point is, na, if you don't know what you are looking for, you will not see it. That happens to us in clinics also. That is the general idea of practicing medicine. If you don't know what you're looking for, ideally you will not be able to see it even if it is in front of you. That is the idea, right? So, the idea is here, you see, they're talking about, it is to read the last line, most appropriate immediate action alongside resuscitation. So, something emergency has happened. Look at this image, placenta is on the outside, it is still attached, there is this redness. So, you can see placenta attached to something. What is placenta attached to? To the inverted lining of the uterus. Right, look at the options, immediate manual replacement of the uterus. The moment I read this option, I know they are talking about uterine inversion. I know they are talking about uterine inversion. So, when you get the gist or hang of it, then when you read the question, you can look at keywords. Otherwise, it will all be gibberish. Right. So, during attempted delivery of placenta, cord traction is applied. So, I am suspecting, okay, the question is about uterine inversion. So, now I can connect the dots. That cord traction applied, she becomes hemodynamically unstable. External blood loss is only little, 250 ml, but yet she is profoundly hypotensive. Why? Now, this is your keyword. What was the keyword? That in uterine inversion, third stage mismanagement context is there, and your initially it is neurogenic shock. Initially it is neurogenic shock. So, these are also keywords that you need to remember. Okay, they may ask you a direct question, they may put it in option, direct option questions. Neurogenic shock is the initial shock that is happening in uterine inversion cases, right? So, examination demonstrate the findings and the fundus is not palpable per abdominally. So, now in this clinical context, if this placenta is still attached to something here, it is, and you know, fundus is not palpable, further supports the diagnosis of acute uterine inversion, right? So, what is the most appropriate immediate action alongside resuscitation? So, answer is yes. What is it? attempt immediate manual replacement with the placenta left attached, right? So this could be morbidly adherent placenta, this could be morbidly adherent placenta also, possibility is there. So no, separating the placenta, no trying to separate the placenta by bits and pieces. First it is repositioning. Now somebody was saying that hydrostatic method. Hydrostatic method is generally reserved when the manual replacement of the uterus fails. Okay, most of the times when it is an acute inversion, your Johnson's method is something that helps. Hydrostatic method we can do as second line. So there is no removing the adherent placenta manually, like I told you. And if we give oxytocin and ergometrin before replacement, we need the uterus relaxed. It is, see, the biggest risk factor for inversion is atonic uterus. That's true. But I want the uterus relaxed when I'm repositioning. Otherwise, I will not be able to push it back in if the uterus is still, if the uterus is contracting, right? Fine. That is why this procedure has to be done in the OT under anesthesia. Anesthesia most of the times is enough to relax the uterus. If not, I may use tocolysis, acute tocolysis, okay? That depends whether I will need or will not need, will depend. Once I've given the anesthesia, if the uterus is still not relaxed, I may take the help of acute tocolysis. That is terbutaline injection, 250 micrograms subcutaneously, right? Then we manually reposition. Once the reposition is complete, if there is a placenta yet to deliver, then we try manual removal of placenta after repositioning. Okay, and once we have removed the placenta, then we can continue with the oxytocin infusion. So right now we don't give, so we give after the replacement is complete. Okay, and bimanual compression and manages isolated uterine atony, that is completely out. Now what, there's no point here in bimanual uterine compression, it is not isolated uterine atony. So Tamil, did you get your answer? How to remove the placenta after inserting inside the uterus? The patient is under anesthesia. Now we are going to remove with manual removal of placenta. We are going to attempt it. Whether we are successful or not will depend upon how is it morbidly adherent and how badly morbidly adherent it is. Okay. Fine. And prolapse nahi hai ye. Prolapse, the reason why it is not prolapse, because fundus is not palpable perabdominally. Okay, not because this has happened immediately. वैसे you are right that prolapse ऐसे immediately, the entire clinical context is for inversion of the uterus, not for prolapse. Okay. Next question. G2P1L1 woman, history of previous cesarean in spontaneous labor, delivered vaginally. While delivering the placenta, umbilical cord gets avulsed and patient starts to bleed profusely. Uterine massage and oxytocin is immediately started. So basically she is having PPH, isn't it? And the placenta remains retained, right? So what happens? She delivered, umbilical cord gets avulsed. This is a retained placenta situation. And don't worry, I am getting your questions, I am seeing your questions, all right. And the idea is that because somebody of you are popping in questions of cervical cancer, in between I am discussing some other question, and then you are popping in some other question, in between I am discussing some other question. Vijay, please remind me of your question regarding updates in the end, because there are a lot of videos circulating in YouTube, I know, with American recommendations, but again, the probability of a recommendation being asked is dependent solely on whether it is being practiced on ground, okay, unless it is something that has drastically changed practice. So I would say keep an eye, but I mean, with ACOG guidelines, they're not, unless they are universally explicitly followed. Otherwise, most of the times it is WHO that needs to be remembered. Okay, how are those guidelines changing clinical practice? If that is relevant, then that can be asked. Otherwise, blanket, nobody will ask you a question, what the OCG says about this particular condition in our country. I mean, I wouldn't be framing a question like that. If somebody does that, I would say it is unfair. Okay, so I will say that to your statement. Coming to this question, what would be the best course of action under these circumstances? Yes, so retained placenta and ongoing PPH. Retained placenta, ongoing PPH. Obviously, you have started with the, when PPH is happening, bleeding is happening, don't forget that uterotonics need to start, okay? The first response treatment bundle needs to start. So, you started with massage, you started with oxytocin infusion. You're taking care of that bleeding also, but now you need to remove the placenta, right? So, when there is an ongoing PPH, and there is retained placenta, then priority is to remove this now, because the bleeding will only stop when the placenta is out and when the uterus will contract, isn't it? So, best course of action would be manual removal of placenta, again ideally in OT under anesthesia by senior person, right? So, controlled cord traction to deliver the placenta right now, no, because ek to umbilical cord has gotten avulsed, so cord is like no more attached to the placenta, so you can't do controlled cord traction anymore. And one, because she is having ongoing PPH, again priority is to go, mobilize her to the OT for that reason. And methergin, I told you, please avoid methergin. When PPH is happening, we are not giving in PPH. Please remember, in PPH, please remember, avoid methergin and injectable prostaglandins if placenta still retained. So, injection methyl ergometrin will not be the answer. And bimanual uterine tamponade, well, bimanual uterine tamponade will only work if the uterus is empty. Okay, right? So, you want to tamponade the uterus. So, the tamponading effect bimanual which we do, it works only if the uterus is empty. In fact, we start with bimanual tamponade once we have ensured that there are no retained products, no placental bits, no membrane bits left inside. Here too the whole placenta is retained. So, there is no point of bimanual uterine tamponade any which ways. So, answer is option number C. So, most of you got it correct. In fact, all of you got it correct. Right. Now, next question. 25-year-old woman delivered her first child by cesarean, which was done for arrest of labor. You are assisting with your senior. Again, I will not ask you to imagine yourself as your senior. No, I mean, examiner will not ask you to imagine yourself as senior. They will always frame it like you are assisting, you are observing, something like this. Okay, most of the time that will be there. So, you are assisting with your senior in a cesarean section, placenta and membranes are expelled, but the uterus remains atonic. Fluid resuscitation is begun, bimanual uterine compression is done, available uterine tonics are exhausted. Pulse rate is high, tachy is there, low BP is there, unit of blood is on its way. What would be the most appropriate next step, right? Now, this question, those of you who are saying option B, I will say balloon uterine tamponade with a deteriorating patient. And see, most of the times the answers to these such clinical questions, when clinical questions are this was an exact question that was asked in your exam. And based on the situations in our labor rooms that we have, the best answer to choose here would have been Beelin's sutures. Okay, because that is what I would do, that is what I think most of us would do in these circumstances, right? That the patient is already on table, already open. We were attempting a balloon uterine tamponade, again ideally in the OT. There were two circumstances where I have used balloon tamponade. One is that patient is delivering vaginally and let's say uterotonics have been exhausted, and after that now I am doing the tamponade thing and then it's not getting resolved and I am resuscitating but the uterus is not contracting, and I decide that okay, let me mobilize her to the OT. In the OT I say okay, let's get everything ready for tamponade. You see, getting everything ready to achieve a tamponade is either there is a Bakri balloon lying nearby, or there is a condom catheter that we can use, and then all that will take up time and prepping, okay. So one thing is I mobilize to the OT, get things ready for tamponading, attempt a balloon tamponade with a hope that I avoid a laparotomy, because if the tamponade works fine, if it doesn't, then I move to a laparotomy. Here the patient is already on table, cesarean section I'm doing. Okay, now my initial response would be the uterus is still atonic, look at her vitals, right? I have requested for blood, it's on its way, uterotonics have been exhausted, she's already open on table. What is stopping me for putting a Belin suture straight away, right? So yes, as your senior here, I would put a Belin suture rather than go for a balloon tamponade. Okay. यार तुम ऐसे कैसे तुमने किया ना, चार्जर पे नहीं लगाया था, तो बात हुई। चलाओ जल्दी। फोन हटा देते हैं। आ जाएगा अब। Okay. Now Pancoast, balloon considered if B-Lynch fails. If you have already applied B-Lynch, तो फिर balloon, how will you insert balloon inside then? After B-Lynch, if we need additional measures, then we can do simultaneously these stepwise devascularization procedures. Okay, and uterine artery embolization is not a procedure for a patient who is unstable and who is having ongoing heavy bleeding. So that is why uterine artery embolization is also out. Okay, and I'm not giving a break because we are going to wrap up. We have a lot of questions to do, and we are not taking a break. Okay, so let's get started. This is written here, bache, woman delivered her first child by cesarean section. You are assisting with your senior. Okay. The placenta and membranes are expelled, but the uterus remains atonic. It is not saying that she is a case of previous cesarean section. Chalo, next question. Most appropriate immediate action, something to do about cord and cord. So this is the situation of cord prolapse. Okay. Now various clinical contexts of cord prolapse can be created. Let's work on the principles. Okay. Now a 30-year-old multiparous woman at 38 weeks is in active labor. She's getting good contraction. So far so good, fine. Uterus is term size, cephalic, free floating head. That's your clue. Okay, because see, again, like I said, I'll keep emphasizing the pointers. The pointers are, know what you are going to look for in the question. Okay, so when you look at the options, you realize they're talking about elevating the presenting part, replace the cord above the presenting part, and putting the woman in Trendelenburg and everything. So they're talking about a clinical context of cord prolapse. Okay. Now, this was a woman with free floating head. There is a loose hanging bag of membranes which ruptures spontaneously and cord prolapse occurs during PV examination. So, this thing happened during PV examination. Cervix is 5 cm dilated, partially phased, liquor is clear. Fetal heart rate suddenly drops to 70 per minute and is not picking up. What is the most appropriate immediate action? Okay, so if you just stay with the clinical presentation here, during PV examination, this has happened. Okay, spontaneous rupture of membrane occurred and cord prolapse occurred. So PV examination was being done and this cord prolapse occurred. Okay, and you know when suddenly this membrane must have ruptured. Okay, cord came out and then the head also dropped down. So that head is putting pressure on the cord compression is happening. Okay, because suddenly the liquor came gushing out. Earlier it was a free floating head, suddenly liquor came gushing out, and then head also dropped down into the pelvis. So what is happening? Cord compression is happening, right? Now what will, supposing if I am doing a PV and I write this question, I give this question to you from my own personal experience, okay? So you do a PV and the cord prolapse happened. The impulse is to, you know, take out the hand. If I take out my hand, what will happen? The cord will come out and in the vagina and then outside the introitus, and then to the outside temperature there will be further vasospasm. Okay, so if I am in a position where while doing the PV, the cord prolapse has happened and the circumstances are like, it is very circumstantial, the circumstances are like this, we have transferred the patient to the OT with the hand inside, sitting by the side of the patient on the stretcher. We have done this. Okay, so elevate the presenting part digitally and prepare for immediate cesarean section is your best answer. So while doing the prolapse happened while PV, so what we are going to do, we are going to slightly lift up the presenting part and push the presenting part up. That is the idea. Okay. All right, but we don't touch the cord. We elevate the presenting part digitally. We don't fiddle with the cord. Okay. So we replacing the cord above the presenting part, that's absolutely out of the question, right? Starting an oxytocin infusion to expedite delivery at 5 centimeter, this is going to be out of the question, right? All the more if we keep giving oxytocin infusion, what will happen? If we give oxytocin infusion, it will further increase the risk of cord compression. So right now, see, placing the woman in steep Trendelenburg position is an option. This option number D is partial correct. Sonam, option number D is partial correct. Why? Because they are saying place the woman in steep Trendelenburg and observe the fetal heart rate. So there is no question of observing the fetal heart rate. So once cord prolapse has occurred, to save the baby, it is an immediate attempt at delivery. Okay, fine. So keep on observing the fetal heart rate is out. So that is why option number D is not the best choice answer. Okay. Putting the woman in steep Trendelenburg, the context would be, and this context also has been asked in your exam, that putting the woman in steep Trendelenburg. Supposing that you are, you are observing a patient in labor room and they give you a clinical context that you are taking the bedside rounds and a woman is in labor, and you look at the local examination, the cord is lying outside the introitus. Now, in that clinical context, cord is already lying outside the introitus, your hands are with you. So, now you don't poke and fiddle at the cord. All the thing that you can do right now is just, put the woman in steep Trendelenburg position so that the cord will slip inside the vagina and cord will slip up. And the head will also move away from the cord and cord compression can be avoided. So, then it makes sense there. Okay. All right. Next question. What is the importance of the following maneuver used immediately? What is the maneuver and what is the situation? So, conducting a delivery of multiparous woman, gestational diabetes in labor, fetal weight is 3.5, shoulders do not deliver spontaneously, head recedes back onto the perineum. This is what we call as the turtle sign. This is what is the scenario of shoulder dystocia. I gave this same question in the LRR session of INI-CET, and then this question was asked in FMG this time, similar question. So what is happening here? What is the importance of the following maneuver used immediately? This is Beck-Roberts maneuver, okay. Beck-Roberts maneuver is when the thighs are flexed onto the maternal abdomen. This is in addition. Applying suprapubic pressure is additional. Suprapubic pressure is additional. Okay, the first maneuver that we do is Mac-Roberts maneuver. Okay, it does not increase the angle of pelvic inclination, it decreases because it tilts the pelvis upwards. Okay, it tilts the pelvis, or it tilts the pubic symphysis upwards. Here it tilts the pubic symphysis upwards, so it causes straightening of the sacrum relative to the lumbar vertebra. That is the way. Okay, so it does not increase the angle of pelvic inclination, it decreases the angle of pelvic inclination, straightens the sacrum relative to lumbar vertebra. So there is space, more space in the pelvis posteriorly, and this shoulder slips out, which is stuck. It does not actually increase the pelvic dimension, it just makes the dimensions more favorable. Okay, it does not actually increase the AP diameter of the pelvis or AP diameter of the inlet. It does not do that, and it does not rotate the shoulders for delivery. Rotating the shoulders for delivery is what we do in the internal rotational maneuvers. Okay, so answer is option number B there. I think most of you got it correct. Some of you got confused between A and B. So it does not increase but decrease the angle of pelvic inclination. Now let's have a look at the next question. So I was telling you I have a question on abruption also. A G2P1L1 seen in emergency at 34 weeks, vaginal bleeding and pain. See, bleeding, altered, dark colored, obviously goes more in favor of abruption. Particularly more in favor, why? Because then it is concealed abruption and blood is slowly collected, blood is slowly trickling out. That is why old collected, dark collected blood, ऐसा लगता है, ठीक है? Altered dark colored bleeding with concealed abruption. But abruption most of the times is mixed. Part of it is concealed, part of it is revealed, or it could be completely revealed abruption also, isn't it? So we can get fresh vaginal bleeding also, right? So vaginal bleeding and pain. Her blood pressure is 140/90. This is another clue. So you can look out for these clues in the question, like risk factors like hypertension is there, clinical context of preeclampsia, under the clinical context of hypertension, under the clinical context of abdominal trauma, right? A woman had a roadside accident, or a woman fell down on the road, you know. So those kind of traumatic incidents as clues are given to you. So some link with the cause. So to separate it from previous associated bleeding, previous painless causeless bleeding, to separate from that context, they may give you some risk factors. She is getting contractions and uterine tone is increased. Tone is increased meaning that she is getting contractions, and in between contractions the uterus is not relaxing completely. That is what increased tone means. In concealed abruption, what happens is that the uterus could be tense, tender, woody, hard also. Okay, in concealed abruption, severe cases, the uterus can be tense and tender and woody hard also. So look out for these keywords also: tense, tender, woody hard, uterus. Okay. And then yes, again tone is increased. Fundal height is at the level of the xiphisternum. Fundal height here is more than the period of gestation. Maybe there is some, you know, retroplacental clot collecting. So that is the reason why fundal height is more. But fundal height could be equal also, could be equal to period of gestation also. Now fetal heart rate is on the lower side. What is the most likely diagnosis now? So most likely diagnosis now is placenta previa. Okay, so now you get it, placenta previa. Sorry, my bad. Most likely diagnosis is placental abruption. Yes, placental abruption is your answer. Previa has painless, causeless, bright red, fresh vaginal bleeding, right? Vasa previa is going to be a different clinical context altogether. Vasa previa clinical context would be fresh bleeding after rupture of membranes and sudden severe fetal distress. Look out for this context, okay, because these are fetal vessels, okay, which are lying in front, naked fetal vessels lying in front of the presenting part. So bleeding is fetal. So that would be the chronology of event would be like this: fresh bleeding immediately after rupture of membranes and sudden severe fetal distress. And polyhydramnios can also cause, you know, increase in fundal height more than the period of gestation. But tone will not be increased in polyhydramnios. Distress goes against the diagnosis of polyhydramnios. So it's not polyhydramnios, right? Now, next question. Now, this is the context of Previa. Okay. Now, G2P1L1 seen at 32 weeks with mild vaginal bleeding. She is hemodynamically stable, the uterus is relaxed, fetal heart rate is 140. So, patient stable, baby fine. Ultrasound done confirms the placenta to be lower uterine segment within 2 centimeters of internal loss. This is low lying placenta. What is the next step in management? Yes. So, those of you who are, yes, Dr. Rahman, concealed variety fundal height will increase considering how much is the retroplacental collection. So, it will, the clinical profile can be a mix and match of situations. Yes, so I will not say fundal height will be increased. What I say is, so you have to also understand the information and read it out in a correct manner. Like saying that with concealed hemorrhage, fundal height is always increased, I won't say that. That is not the correct way to remember it. The correct way to remember it would be that if there is a clinical context of placental abruption and we are suspecting placental abruption, right, in that context, if the fundal height is elevated more than the period of gestation, that goes more in favor of concealed abruption, right. So, the patient, so by the time there has been such significant, come to think of it, answering whose question? Who asked me this very interesting question? Ahmed, yeah. So, you asked me this question about, so what was I saying? I was saying that by the time that there has been concealed hemorrhage to the extent that it has caused an increase in fundal height. Okay, so that means that there has been, let's say, so much of blood collection in the retroplacental area, right? So, we're talking about a situation where, let's assume, most likely, much of the placenta, almost all has separated. In behind that placenta, up to about 1500 to 2500 ml of blood loss could have been collected. So, by that time, we are expecting the clinical profile would be that of an unstable patient with probably a dead baby. Right, so it has to, it's like a puzzle that has to fit the pieces, right? Okay, so that's the idea. Now this question, yes, so 32 weeks and this is mild bleeding and this is, they are not mentioning that this is persistent bleeding or that is the second bleeding, right? And this is the way the question was asked. The idea is that she is hemodynamically stable and uterus is relaxed for now. So, as such right now, the priority is that we admit her, okay, and we start with the conservative management, right. The first episode of bleeding in placenta previa is usually a warning hemorrhage that it subsides on its own, but it can happen anytime and there is no way predicting when will it happen again and how bad it will happen again, right. And as and when she will go into labor, then also previa patients will bleed, right. So, yes, there has to be delivery by cesarean section. Such patients will always be delivered by cesarean section. But for now, at least we will go for conservative management and start steroid. She is less than 34 weeks. She is less than 34 weeks. So, I keep her admitted, okay. I keep her admitted, vital charting, vital monitoring, keeping a watch for bleeding PV, keeping the blood arranged, calling people, informing them that I have admitted such a patient in the ward, right, and starting with the steroids with the hope that, okay, at least the steroid cover gets completed in the next 48 hours. If at any point in time she starts to bleed again, she starts to get unstable, she probably goes into labor, then I'll have no choice but to stop with the conservative management and deliver with cesarean section. So, there is no immediate induction, so is out, there is no vaginal delivery here. Low-lying placenta and placenta previa, please remember that there is no vaginal delivery to at all, that is not there, okay, there is no vaginal delivery, it is always cesarean section. So, induction of labor out. Immediate I will not say, cesarean section at 37 I will not say. The goal is, she is 32 right now, the goal is to take her till 37, but I mean I can't say that I will plan her at 37, I mean that kind of Future prediction we can't do, na. So right now they are asking you next step in management is to give conservative and start steroids, right? That is what we call as the McAfee and Johnson's regimen. Yes, you are right. You are right. It is called as the McAfee and Johnson's regimen, right? So when you are saying no, when you say dear students, when you say na you misread the question, POG nahi dekha, all except nahi dekha, most of the time these are the kind of mistakes that you are making. So it is a very good to analyze where you are making mistake. Is the mistake conceptual or is the mistake silly? Silly mistakes can be easily corrected. Conceptual, I am there to help you. You ask me the question and we are going to go with improving the concepts, okay? Now, so please remember here that at any point in time, let's say for example, if a woman is already more than or equal to 37 weeks, she is already in labor or she is unstable, okay, or the baby is already dead or there is fetal distress, baby dead or fetal distress of a viable fetus, fetal distress of a viable fetus. Come to think of it, the only reason why we were doing conservative management was for the baby's sake. We were doing conservative management in previous patient for baby's sake, so that we could at least give this steroid course and buy some time and hopefully, you know, take the pregnancy as close to 37 weeks as possible. But if baby is out of the equation, if baby is already dead or there is fetal distress and the fetus is viable, then these are indications for emergency cesarean section in these patients. Okay, clear? Right? And for somebody who has never bled, let's say there is a known case of placenta previa, because we are doing routine scans in pregnancy. Supposing that routine scan in pregnancy, the level 2 anomaly scan was done. Level 2 anomaly scan, placenta was low lying. Then we repeat the scan at 32 weeks. Then we repeat again at 36 weeks. At 32 weeks, we repeat first. If it is still low lying, then we again repeat at 36 weeks. 36 weeks, it is still low lying. Then we plan. Never bleed. We plan an elective cesarean section at 37 completed weeks. Okay, keep that in mind as well, right? Now, Dr. Ahmed, classical cesarean section we will do in this, not necessary. Not necessary. Not necessary. Why classical? If the placenta is posterior, you can open the lower uterine segment. What is the thing? Right? And it's not necessary classical, and it all depends on case to case where it is in the lower uterine segment. Okay, if is it going to come all the way into your incision line? Sometimes we cut through the placenta, sometimes we don't cut through the placenta. So there are various techniques to avoiding giving low incision on the lower uterine segment. So I won't say that it is always a classical cesarean section. Now next question. A 35-year-old primee is seen in emergency at 32 weeks, BP 160 by 110. Your context is set, okay? 32 weeks, severe hypertension. Urine albumin 3+, this is severe preeclampsia. Clinical context set. Next step they are asking you based on the Doppler findings, because I read through the options. Repeat Doppler, monitor, admit and deliver, admit and this and deliver. Okay, so let's look at this. Severe preeclampsia. So what I want to find out while reading this question is, can I keep repeating Doppler after 1 week, or can I keep monitoring, or do I need to do something right now? This is severe preeclampsia. Just monitoring will not be the answer. So I have not even read the question. Okay. So repeating and 1 week time and keep monitoring alone, this doesn't seem like very good. The whole idea is immediate delivery or not. The whole idea is immediate delivery or not. Okay. So while reading the question, what you should be looking for in this question is there any reason to deliver right now? Because she is 32. If she was 34, completed or more, I would have delivered her. Okay, fine. So she is 32 now. All right, so let's read through it. Her initial lab report show HB, TLC, this platelet is on the lower side, no complaint of headache, blurring of vision or epigastric pain. So there is no sign and symptom of impending eclampsia. So if there was impending eclampsia or there was eclampsia or there was HELP syndrome, right, then I would have delivered immediately. Okay. Ultrasound shows 28-week parameter oligo absent end diastolic flow. Absent end diastolic flow is now see, this question mixes preeclampsia and the possibility of having a growth restricted fetus with preeclampsia. Okay, fine. So this question mixes two separate topics. Alright, so here there is severe preeclampsia complicated by fetal growth restriction and there is also absent end diastolic flow. Now again here, if she was already 34 weeks with absent diastolic flow, also there was no question, I would have immediately delivered. Okay. So right now I don't think there is a reason for immediate delivery. She's 32. What we can do right now is initial management would be to admit antihypertensives, at least start with the steroid cover, start with the magnesium sulfate, severe preeclampsia, okay, prophylactic magnesium sulfate for neuroprotective action and monitor with NST and biophysical profile. Okay, this magnesium sulfate here, see severe preeclampsia less than 34 weeks, right? These patients also need prophylactic magnesium sulfate. Keep that in mind. Okay, fine. So the best answer is option number D. Yes, if there was reversed end diastolic flow, then there would have been immediate delivery, right? This magnesium sulfate we are giving, bache, severe preeclampsia patients, prophylactic magnesium, so that prophylactic magnesium sulfate for prevention of convulsions. She is a very high risk patient. If you read through a profile, her platelet is also on the lower side. Maybe the other features of headache and blurring of vision are not there, but what if during the course of admission and we are starting with the conservative management and steroids and everything, and by the evening she worsens, what then? You see, such patients with severe preeclampsia, they can worsen. The preeclampsias are especially like that, they worsen. One moment they are fine, next moment you come on evening rounds, they are worsened. Or every time morning, evening rounds, we ask them, do you have any headache? Do you have any blurring of vision? We tell them, if you feel this, then please report. They are admitted, they are kept under strict BP charting every 4 hourly, input output charting we have to see, right? Because at any moment at any moment if she is worsening, deteriorating, having signs and symptoms of impending eclampsia, has a convulsion, or her lab parameters are worsening, or BP is not getting controlled. So she has to be started on antihypertensives also, no? Blood pressure also has to be controlled. So at any point in time she is worsening, you stop the conservative management and you deliver. Clear? So you got, what if signs of end organ damage were present? Signs of end organ damage, see there are few indications where you have to deliver irrespective of POG. Impending eclampsia, HELP, and in the clinical context, remember placental abruption also. Placental abruption with preeclampsia. So we are talking about clinical context of preeclampsia. Signs and symptoms of impending eclampsia, HELP, placental abruption, and for the fetal case also, fetal distress of a viable fetus. Okay. So all these are indications to deliver immediately irrespective of period of gestation. Okay. Signs of end organ changes is a very blanket term that you are giving me. What signs of end organ changes you are talking about? वो तो यही आ गया, signs and symptoms of impending eclampsia. Headache if it is there, blurring of vision if it is there. Okay, severe epigastric pain if it is there. These are signs and symptoms of impending eclampsia, right? So of course these are signs and symptoms also of the end organ involvement of the brain cerebral circulation and the liver and the right. But the point is that if you have just lab parameter and HELP syndrome mein aa gaya, hemolysis, elevated liver enzymes, low platelets, that group as a whole, right. And other than that, for the undergraduate level, please remember, we don't ask you gray zones, all right. Other than that, what we tend to do is we keep a very close watch for the blood investigations. So again, worsening over time, and we may have to repeat the labs daily. So we have to see the trend of how much can we persist with the conservative management. So it is managed, the decision is updated on a daily basis, whether we can continue today or not, okay, right. Yes, so this blurring of vision, scotoma, diplopia, these are all signs of end organ involvement to the extent that she may throw a convulsion at any time. So that's why impending eclampsia, right? Okay. Now, you meant to ask uncomplicated preterm labor, do we add magnesium sulfate for fetal neuroprotection at less than 32 weeks? Yes, we do. That is the recommendation. The practice is otherwise on ground not universal. So if you've not seen it happen, it's okay. But that is what the recommendation is. For just preterm labor less than 32, usme bhi the practice is not universal in the sense that some, again, reputed guidelines, different guidelines say different thing, less than 30 to 32 weeks. So practice may differ, but that is what the recommendation is. Yes. Okay. Next question. A patient is diagnosed with twin pregnancy at 26 weeks of gestation. Ultrasound shows a single placenta. Single placenta. First twin weighs 500, the second is 1100 grams. So you see discordant weight. Okay. Discordant weight is at least 20% discordancy has to be there, right? This is definitely more than that. And what we are also seeing here is single deepest pocket. Please, I want to highlight this point to you that when you are given amniotic fluid measurements in twin pregnancies, you see inside there are two fetuses. So AFI is no longer applicable, okay, 4 quadrants belonging to 2 fetuses. AFI is no longer applicable, it's SDP, single deepest pocket. So that means that intertwin membrane on one side of the intertwin membrane and on the other side of the intertwin membrane, see 2 single deepest pockets. One is measuring 1 centimeter, other is 12 centimeter. So this is less than 2 centimeter, this is more than 8 centimeter. So this is obviously oligo and poly, right? So this is twin to twin transfusion syndrome. The first stage is already there, right? What is the first stage? The first stage, which is the stage I'm talking about? I'm talking about Quintero staging, right? I'm talking about Quintero staging. This is twin to twin transfusion syndrome where there is, oligo and poly is also there. Okay, twin anemia polycythemia sequence is in this, there is only twin anemia and polycythemia, nothing else is there. Weight discordance is not there, oligopoly is not there, right? And this will be, how do we check for anemia? We check the middle cerebral artery Doppler. This is antenatal diagnosis of twin anemia polycythemia sequence is made on antenatal MCA Doppler. Okay, and this is no longer IUGR of first twin and normal second twin. It's very difficult to say if this is IUGR of first twin and normal second twin. We can't say that. For that, we will have to do further monitoring. We can't say it is normal second twin because oligopoly has set in. This is a single placenta. So most likely this is monochorionic diamniotic with the description that is being provided. And again, because oligo and poly is there, best answer to choose is twin to twin transfusion syndrome. And right now, yes, so Quintero staging, my dear friend, NEET PG aspirants, they asked Quintero staging question in the recent FMG examination. Please make sure that you recall this Quintero staging also. This was asked in a recent examination, okay. So stage 1 is oligopoly, stage 2 is bladder of the donor twin is not seen, 3 is Doppler changes, 4 is hydrops in either twin, Doppler changes can be in either twin, and 5th is death of either twin, right? Yes, Quintero staging, clinical staging, yes. This is stage 1. Stage 2 is bladder of donor twin not seen. Stage 3 is Doppler changes. Stage 4, Doppler abnormal. Stage 4 is hydrops. Stage 5 is death. These can happen to either of the twin. To either of the twin. Okay, fine. Next question. So I got somebody asking me questions on RH negative also. Who was that? So it has gone very high up in the chat box, right? So somebody was asking me a question on RH negative pregnancy. So if you're there, please put that question again as to what exactly was your doubt. This is a question. Let's see. 26-year-old RH negative woman had one full-term pregnancy 3 years ago. Husband is RH positive. She is unsure whether she received anti-D immunoglobulin after delivery. The child was later found to be RH negative. She is now planning another pregnancy. What is the most appropriate next step? Right. Is there anybody else who's saying anything other than D? Is anybody saying that? Somebody is saying B. Yes. So I'll get to your doubt. Somebody is saying B. A. Okay. All right. Another question, another doubt about the dosage coming up. All right. So the correct answer to this question is D. Okay. The correct answer to this question is D. So you have to understand, and you know, like, come on. I mean, she's now planning for another pregnancy. All your flow charts, okay. This is how we say, you know, that if something is not mentioned in your flow chart, or if something is like I don't want to sound mean, okay, but the point here is that you have to think beyond what may always be laid out in plain, simple, you know, flow charts, right? Like for example here, and that is what, when the concept is not clear, then a mere twisting of the language does this. And this is what they did for the FMG students. So the question, why am I discussing this question? So that we can discuss RH negative pregnancy. That is why this question has been kept here. She is now planning another pregnancy, right? So she is nowhere near pregnant. All right. So if she is sensitized, if she is not yet sensitized, it doesn't matter. Whatever prophylaxis that we have to give, we have to give it in the antenatal period. It is either in the antenatal period, you have read about prophylaxis, routine antenatal anti-D prophylaxis, or you have read about a prophylaxis that is done immediately after delivery. These are the two places where you have read about prophylaxis. Now she had a delivery 3 years ago. Okay, she is unsure whether she received anti-D. The child was later found to be RH negative. Arey bhai, that is why she was never given anti-D injection, because that child was RH negative. Obviously, they must not have given. Or even if this child was RH positive, let's assume recall was not correct, or they had mentioned RH positive. Let's say that child that she delivered 3 years ago was RH positive. What can be done about it now? What can be done about it now? If she has been sensitized, she has been sensitized in this pregnancy. If she's already been sensitized, then what can be done about it now? Nothing can be done about it now. Okay, so no anti-D prophylaxis is required right now. Clear on this? This was not a hard question. This was not a hard question. This, I would say, at best, trick question. Okay, so if you look at this, administer anti-D immediately before conception. Nowhere has it been taught. There's absolutely no role of giving anti-D before getting pregnant. Okay, right. Now, why not B? Perform an indirect Coombs test to assess maternal sensitization. Okay, you did. You assessed maternal sensitization. Negative. She was not sensitized. Good. Positive. She is sensitized. What now? Does it change anything? It doesn't change anything. It doesn't change anything. No anti-D prophylaxis right now and reassure. Okay. So, doing this indirect Coombs test achieves nothing. It doesn't change the management. Okay. It is just an unnecessary expenditure. With that information is of no use right now at the moment while she is planning for another pregnancy. And also the reason and why in this particular question it is not the answer. Why in this particular question it is not the answer? Because the child was later found to be RH negative na baba. Arey, so why will she get sensitized in her first pregnancy bhai when she was carrying an RH negative child at that time? So why will you do this test and waste the money of the patient? When you know that the chance of sensitization is not there until unless the husband was not the father, whatever, like, so please, right? So that is, it's not, it's unlikely, it's very unlikely, right? Because the child was later found to be RH negative, that child that she was carrying was RH negative. So obviously the chance of sensitization happening in the pregnancy that she was carrying is nil. Sensitization happens when an RH negative mother carries an RH positive child. That child was RH negative, isn't it? Now, if the child was RH positive in this case, then also like I said, Animat, then also like I said, if the child was RH positive, then even if you did this ICT, you came to know that the patient was sensitized or not sensitized, it will not matter right now. Right? As and when she will get pregnant the second time, as and when in her next pregnancy, she will be managed. Then you will do the ICT, she will be managed as usual. As usual, nothing changes there, right? Acha, I'll give you an example. I'll give you an example. Okay, yes. If option had first ANC visit added, then it would be B. Excellent. Who's saying dear? Yes. 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 If this was her first antenatal visit, then answer would have been B. This you would do in the first ANC visit. Whenever she gets pregnant, next. Whenever she gets pregnant, next. Acha. Now let's take for example, okay, just to argue, somebody who was saying why not B? What if she was RH positive? Okay. What if the child was later found to be RH positive? There are so many RH negative women, then they deliver RH positive baby. Okay. And we give anti-D injection. Okay. We give anti-D injection after delivery. Then in their next pregnancy, do we check before pregnancy that have they gotten sensitized or no? No, we don't check before pregnancy. Have they gotten, or the anti-D that we gave, was it effective in preventing sensitization or no? We don't do that. That is unnecessary investigation. It serves no purpose at that point in time, right? Whatever management has to be done as and when pregnant. So again, option number B is not correct. Okay, and anti-D only after the delivery regardless of the baby status, that's also absolutely wrong answer, right? So ICT in a next pregnancy, ICT, if it is negative, if it is positive. If it is positive, then we start doing the titers. If it is negative, then we again repeat ICT at 28 weeks. And if it is negative again, then we give anti-D. We give 300 micrograms IM, and then she will deliver. After delivery, we give anti-D if baby blood. After delivery, if baby blood group is RH positive, then we give anti-D. Okay, that is what we do. Now somebody is saying, dose. Dose is a important question. Dose is, see, it's only ACOG which says less than 50, less than 12 weeks, give 50 microgram. And we have started following the Foxy recommendation. These are for us. So it clearly says less than 20 weeks, 150 micrograms, and more than 20 weeks, it is 300 microgram full dose. Okay? So that controversy is solved. There is no controversy there at all. Now, why we give anti-D post delivery even if sterilization is planned? Because people can change their mind. They may not want to get a sterilization done later. Life happens. They may want a reversal of sterilization. I mean, these are, so it is better to give. I mean, I think that is the only reason. Why give anti-D post delivery even if sterilization is planned? Because she may want, what are you saying, that she'll get sterilized straight away? Or she may get sterilized after a couple of months, and then, you know, like, that's why. I think that's the answer. Next question. So I got few questions in the chat box regarding cervical cancer screening. So let's discuss your doubts regarding that with this question. A 35-year-old sexually active woman visits gynae OPD for routine checkup. She is concerned because her mother died of cervical cancer at the age of 45 years. What would you advise her? How many questions are left? Not much questions are left. What would you advise her? Yes. She is right now 35-year-old. Cervical cancer has got no genetic component, right? So this BRCA testing and HNPC testing, this is for Lynch 2 syndrome, right? This is for hereditary ovarian and endometrial cancers, right? BRCA is for, again, hereditary ovarian cancers, right? So the differences between HPV vaccination and cervical cancer screening. Yes, you are right. I need to go a little bit fast. Yes, you are right. I need to go a little bit fast, and I maybe need to do away with a lot of doubts, right, so that we can complete this. So the correct answer to this question is cervical cancer screening, right? So she is 35-year-old. See, the priority age group for vaccination, the priority or the primary target age group for vaccination is 9 to 26 years. Even in that age group, with the primary target, even in that age group, the primary target age group is 9 to 14 years, sorry, 9 to 14 years. And the secondary target age group is 14 to 26 years of age. So up till 26 years. Beyond 26 years, it has to be done on a case-to-case basis. We routinely do not recommend vaccination beyond 26 years. So beyond 26 up to the age of 25, case-to-case based decision has to be taken. So yes, she is not in that age group. Secondly, vaccination is not 100% preventive. Vaccination will only prevent against the acquisition of strains, against acquiring the strains that the vaccine contains, right? So we have this Gardasil, we have the Servavac, which we have 4 strains, right? Or even the Gardasil 9, which will have additional 5 high-risk HPV DNA strains, only protection against those strains. So vaccination is not 100% protective. Getting vaccinated after already being sexually active for a couple of years, okay? Then what happens is that it's not a contraindication that sexually active women, we will say that now you are already sexually active, don't get vaccinated. We don't counsel like that. But the idea is that we have to tell them that it is quite possible that we have to tell them that the vaccination is 100% not effective, because she may already be acquired those strains of HPV, right? So the efficacy will be reduced in somebody who's already sexually active. But that doesn't mean that we don't need to give those vaccines, or we should deny vaccination to those women who are requesting for it. Clear? So keep that concept in mind, right? So HPV vaccination is not the best choice answer. Even those vaccinated, they need to get themselves screened. Even those vaccinated, so even these young girls, 9 to 14-year-olds who are getting vaccinated, they will need to get themselves screened any which ways. So for this particular patient, it is better that she goes for cervical cancer screening. Okay, so the best choice answer is option number B. All right. Now, Let's have a look at the next question. In which patient with atypical glandular cells on pap smear undergoing colposcopy, when would endometrial sampling be advisable? Right. So, atypical glandular cells, they asked in INI-CET, then they repeated in FMG, I believe, and then I don't think they have not yet repeated in NEET. Right. Now, so vaccine questions, 3 dosages versus 2 doses, we follow Government of India or SAGE. SAGE has been accepted by Government of India, it looks like that. How do I say it? Because see, the manufacturing label talks about up to 14-year-olds, 3 dosages, less than and 2 dosage, up to 14-year-olds, 2 dosages, and more than 14-year-olds, 3 dosages. Okay, so the traditional schedule is, let's call it the traditional schedule is less than 14-year, 2 doses, and more than or equal to 14-year, 3 doses, right. Now, the SAGE recommendations from WHO was for adolescent girls, So, for adolescent girls, meaning they said up till the age of 19, they said that reducing the dosages. So, adolescent girl is up to the age of 19. Okay, they said reducing the dosages is fine, 1 or 2 doses, 1 or 2 doses. This is the summary of SAGE recommendation. Reducing the dosages is fine, right. So, the idea of SAGE recommendation is to improve the coverage in low resource settings, that at least these adolescent girls, they at least get 1 dose. That is the idea. Okay. Now, the Government of India in February or March conducted this nationwide vaccination drive, where they vaccinated 14-year-old girls in designated centers and all district centers with a single shot of the Gardasil vaccine. That they did. Okay, so considering that, it seems like we are moving in the direction of accepting these SAGE recommendations. अब वो जब आ जाएगा ऐसा circular, या it may be incorporated in the, whether it will get incorporated in the immunization schedule, that's another matter. जब वो हो जाएगा, then 100% I can say that हाँ, Government of India has said that give 1 dose only, because that is what the immunization schedule says. But ऐसा नहीं है अभी. Right, filhal. But yes, it seems like we are moving in that direction. Most likely, we have, Government of India has accepted. That is why they created that drive. But abhi uska proof nahi hai. This is proof of concept. It looks like it, that we are going ahead in that direction. Coming to this AGC, atypical granular cells on pap smear on colposcopy. So, on colposcopy, we are able to visualize the ectocervix, right, and the transformation zone. With some degree of manipulation, some part of the endocervical canal, little bit we can see, but not much more than that. If there are atypical glandular cells on pap smear, glandular cell can come from 2 locations, endocervical epithelium and endometrial epithelium, right. So, when you have atypical glandular cells on colposcopy, on pap smear, along with colposcopy, one also does endocervical curettage. One also does endocervical curettage or endocervical sampling. And we also add endometrial aspiration if risk factors for endometrial pathology is there, right, or if the woman's age is more than or equal to 35 years. Right. So, with AGC on pap smear undergoing colposcopy, when would endometrial sampling be advisable? Well, with regular cycles, no. In a asymptomatic woman, no. There is no reason why somebody on hormonal contraception without bleeding, why? But somebody with intermenstrual bleeding points towards the possibility of endometrial pathology. That is why B is the answer. Okay. Now, Bashisht Dev, becha, HSG, Mullerian anomalies, we are having a figure based, image based, only image based work through. I think it is being planned in this coming week, and I am going to take it up. We are discussing clinical questions today. All images I will show you, as much as I can show you, jam packed session on images on 14th. Or yeah, I think it is on 14th. Okay. Now, when do we choose conization instead of LEDs? Very limited indications of choosing conization these days. Conization when I have a clinical suspicion of adenocarcinoma. Adenocarcinoma clinical suspicion based on the biggest, I'm starting with the most obvious indication of conization, right? When I have a clinical suspicion of adenocarcinoma, like for example, if there is clinical finding, or again she may have this atypical glandular cells flavoring neoplasia. Okay, and then maybe I have done an endocervical curettage, and that curettage is coming equivocal, or the curettage is coming suspicious. Then I want to see the entire conization because of clinical suspicion of adenocarcinoma, or my pap smear reports show me adenocarcinoma in situ like cells. Then I want to do conization, obvious indication, clear cut, no doubt about it. Or when my clinical findings are showing a ballooned out cervix, right? Maybe she has a history of close coital bleeding. Maybe I'm suspecting that there is an endocervical component of growth. So I would say the biggest indication of conization in current practice would fit under some pointer or some clinical suspicion based on PAPs or based on clinical examination findings which are raising the possibility or suspicion of adenocarcinoma, where I want to analyze the whole, take out the entire cone of the cervix. Okay. हाँ, yes, LRR भी आ रहा है 12 को, that is on the app. Now look at this question. A 46-year-old woman complained of postcoital bleeding and she is found to have cervical erosion on post-speculum examination. This question has come in your examination. It's a previous year question, but at that time it did not come with an image. I want you to see this image of cervical erosion. Okay, so I kind of filled in the question with image and then build on it. So this is the image showing cervical erosion. Erosion is simply nothing but the pouting out of the endocervical epithelium on the ectocervix. So what we call as ectropion, it's the same thing. What we call as ectropion, it's the same thing. All right. Now also please remember here that yes, also please remember here that questions on postcoital bleeding have been asked in your recent exams in some form or the other, right? Now, cervical erosion, please remember, is not like there has been ulcer or something on the cervix, okay? This is just endocervical epithelium pouting out, all right? Keep that in mind. Now, the correct answer to this question, all of you answering correctly, liquid-based cytology, HPV DNA testing and cervical biopsy. So, some form of PAPS, some form of cervical cancer screening has to be put in place, okay? Now, in our country, most of the time, women are not appropriately screened. Okay, so it is important that we ask, have you got recently screened? Is there a recent screen available? 9 times out of 10, there is no recent screen available. So might as well, when we are doing this examination, at that time, just take a sample also for whatever test we have, whether we have PAPs, then liquid based cytology we can take, HBV test, DNA testing we can do on the same sample. So whatever we have available with us, we do, and depending on that report, we move further. So if there is abnormal pap smear report, right? So let's say if there is postcoital bleeding, okay, either we start with post-speculum examination. If we see a growth obvious, then we take a biopsy, and if we see no growth, then at least we do a PAPS. We do some PAPS or HPV or whatever. So whatever cervical cancer screening we have with us, we do, and then we later call for colposcopy. Later we call for colposcopy. Supposing there is a woman with persistent symptoms are there and normal screening results. Then persistent symptoms with a normal screening result is not very reassuring. Please remember, screening have false positive, false negative. Then also be subject to colposcopy. Okay. यार मैंने पेपर थोड़ी बनाए, अब कितने क्वेश्चन आएंगे ऑब्स गाइनी में 180 में से, मोस्ट ऑफ द टाइम्स 15 to 20 क्वेश्चंस, ऑड क्वेश्चंस तो आते ही हैं, बट अगेन दे कीप चेंजिंग. Like last year exam, the NEET PG had less obs gynae questions, right? And postcoital bleeding and abnormal looking cervix, obviously, if there is no obvious growth, but there is an abnormal looking cervix, we go for colposcopy. Like, so if there is, what did I write? If there is abnormal screening result or there is a suspicious looking cervix, then also we go for colposcopy, right? So these are these images I want you to keep in mind, because I will not show these images late. The images that I show today, I will not repeat them, right? So these two images are showing growth on the cervix. Okay, so the growth could be an ulcerative growth as the image on the right, or it could be a fungating cauliflower like growth also, right? Now see what we did, we subjected this woman to colposcopy. See, this is the abnormal white area, under magnification we are seeing. Then we did apply Lugol's iodine also, and we saw the abnormal area yellow. So we could identify the abnormal area and we could take the biopsy. That is the advantage of colposcopy. Colposcopy identifies the abnormal area to biopsy. The principle is the same. Visual inspection with acetic acid applied on the cervix, abnormal area looks white, right? Lugol's iodine applied on the cervix, abnormal area does not take up the stain of iodine, seems yellow. Principle same. Visual inspection, look at the cervix without any, with just white light. Same things done, acetic acid applied on the cervix, Lugol's acid applied on the cervix, Lugol's iodine applied on the cervix, but look at the cervix under magnification, that is colposcopy, identify the area to biopsy, right? And the image on the right here, is showing again a woman who came with the complaint of postcoital bleeding, and she had an endocervical polyp. She had an endocervical polyp. This small polyp was just here at the endocervical canal, was the base of the polyp, okay? And please, when we do see an endocervical polyp, it doesn't mean that we don't follow. When we do see an endocervical polyp, it doesn't mean that we don't do the pap smear screening or anything, okay? We do the screening also. Okay, so keep that in mind. This polyp cannot be taken as the isolated explanation of the postcoital bleeding. It is very important to take some or the other, whatever is available to us, cervical cancer screening sample. Next question, upping the question. All right, so recently I have seen a trend, they are asking you questions about radiotherapy, all right. Now they ask you the question on principles of radiotherapy, and they give the context of cervical cancer, because cervical cancer, I think, is one cancer where radiotherapy is pretty very effective, all right. So they do this. So let's have a look at this. 32-year-old woman counseled before concurrent chemoradiation for stage 2B cervical cancer. The profile is that she has to receive chemoradiation because she is having stage 2B cervical cancer, even though she is 32-year-old, because this is inoperable now. She asks what to expect regarding her reproductive and pelvic organs. What is the correct statement? Yes. Excellent. So ovaries are radiosensitive and radiation will cause ovarian failure. That is correct, right? So please recall and remember, I will give you the key pointers here. How does radiation work? How does radiation kill cells? Radiation kills cells. Why? Because it acts on the rapidly dividing cells, right? And that toxic radicals are built up during that time, and then that kills the cells. So obviously rapidly dividing cells of the ovarian germ cells, right? Or of the gastrointestinal epithelial lining, or the urothelial lining of the bladder. So these are the organs in the vicinity of the target tissue. Target tissue is cervix, where we have to deliver the radiotherapy. But structures in the vicinity, in the field of radiation, they will anyways bear the brunt of radiotherapy. So there will be side effects of radiotherapy, right? So long-term side effects of radiation are happening because of obliterative end arteritis. I want you to remember this, obliterative end arteritis, okay? First thing this. So this is pretty obvious, this is pretty something to be expected. Now ovaries are not radio resistant, hormonal function is not going to be preserved, that's not correct, right? Even though we are not removing a uterus, there is no question of fertility being maintained, obviously, because ovarian function gone, and vaginal function is also going to be unaffected. No, these women, they tend to have vaginal stenosis, okay? They tend to have vaginal stenosis. So their vaginal function, in the sense the sexual function will be affected by pelvic radiotherapy. That's an expected side effect, right? So keep these important pointers in mind. The other thing that I want you to remember is that what we do to prevent the radiation related side effects to the adjacent tissues. The idea is that we deliver the maximum dose to the target and less than less dose to the nearby tissue. So remember that the dose of radiation, see, they ask you these terms, they mention these terms, but when you remember it in principle, you understand and remember, right? So the dose of irradiation that you have to give to a tissue will, the dose that you can give to a tissue will depend upon how far you are keeping the radiation source, right? Obviously, na, near to the tissue, radiation dose will be more, further away the radiation dose will be less. So dose of radiation is inversely proportional to the square of distance, something that we have mugged up, but the idea is that the nearer the source of radiation is to the tissue, more radiation reaches there, and further away then less dose reaches there, right? So in cervical cancer therapy, we use this principle to tailor the radiotherapy to the patient. So we have two types of radiotherapy, something that we call as teletherapy and something that we call as brachytherapy, isn't it? Do you recall or not recall? Have you remember? So this teletherapy is EBRT, external beam radiotherapy, right? So source of radiation is outside the body, and then the source of radiation is outside the body, and then the radiotherapy is given to the entire pelvic field, right? And maybe extended field sometimes if para-aortics are also involved. And brachytherapy is what we call as intracavitary brachytherapy, right? So the radiation source is kept inside the vagina in brachytherapy. Okay, radiation source is kept inside. These are colpostats or tandems that are kept inside the vagina. Idea is that the cervix gets the maximum dose and the tissues further away, the nearby tissues, they get less dose. So we use a combination of these when we have to tailor the radiotherapy to the patient's requirements. Okay, so keep that logic in mind, all right. Now, moving on the next question. So, I was getting questions regarding fractional curettage, gold standard, this and that, right. That's not for postcoital bleeding, bache. Postcoital bleeding is a very specific complaint for a contact bleeding that is happening. Postcoital bleeding is a contact bleeding, a very specific complaint for some lesion on the cervix. Usually your questions are asked in the clinical context of cervical cancer and CIN, right? There could be cervical erosion, there could be cervicitis, cervix could be inflamed, and she could be having a cervicitis because of sexually transmitted infection. So it could be a transient complaint because of that. So there could be other causes also of postcoital bleeding, but again, one has to begin with one can't ignore the fact that it's a very specific complaint for cervical cancer and CIN lesions. So that is why screening has to be put into place. Think of it like an opportunistic screening. This is an opportunity to do these tests in these women. Now that they've come with the complaint of postcoital bleeding, I would like to remember it like that. So do not forget that, right? And that's because of the context, that's because of our clinical context, where the women are inappropriately screened. In general, they are not getting themselves screened. Screening is poor, not that good. Now, 45-year-old multiparous woman, obese, hypertensive, is seen with complaint of heavy menstrual bleeding over 1 year. So, abnormal uterine bleeding here, your age more than 40 years, right, or endometrial thickness more than or equal to 12 mm, or it can be done earlier also if risk factors for endometrial hyperplasia and cancer are there. At least remember these three, mota, right. So, she is obese, hypertensive, she is more than 40 also, she is obese, hypertensive also, right. Her pelvic examination is otherwise normal. Now, TVS shows a 3 centimeter intramural fibroid, ET is 10. Even though the ET is 10, I would still say perform endometrial aspiration is the next step in her evaluation. Even if we find a small intramural fibroid also, then also it is important to go for endometrial aspiration. Please remember this, right? Endometrial aspiration is one investigation because we have to have a histopath. It has the potential of changing the management. Fibroid, clinical conditions like fibroids can coexist with endometrial hyperplasias, right? So if there is atypical endometrial hyperplasia, suppose, because this small fibroid may not be contributing to her heavy menstrual bleeding. It may not be the explanation of her heavy menstrual bleeding, right? So atypical endometrial hyperplasia, if we discover, then it will deserve a hysterectomy. So it has a potential, this investigation has potential of changing management. So that's why it should definitely be done. Another indication is after failed, let's say maybe somebody has tried medical management and then after failed medical management also one should attempt this endometrial aspiration. Now if on tamoxifen therapy, what is the ET taken cutoff? It's the same. With tamoxifen therapy, the cutoff of ET does not change. But tamoxifen therapy, in fact, tamoxifen therapy if she's having bleeding on tamoxifen therapy, then the idea is that even with less ET, then I may want to take the sample because that therapy itself is a risk factor. You see, right? So performing hysteroscopy, unnecessarily invasive. Hysteroscopy can be done at a later step. Hysteroscopy can be done at a later step. What are the indication of hysteroscopy? Indication of hysteroscopy is, let's say, anything where we are having suspicion of intracavitary lesion, So she may be having persistent intermenstrual bleeding, or she may be having persistent symptoms after a normal sampling report or after a normal curettage report, and we want to further investigate the uterine lining. So these are the two broad indications of intracavitary lesions, right? Now proceeding with hysterectomy is unnecessary procedure. It is unnecessary. Nowadays we are moving away from hysterectomy, okay? Please understand here, we are moving away from hysterectomy for benign reasons. So nowhere will it be justified to do a hysterectomy for a patient with just a complaint of heavy menstrual bleeding. Ye jo DUB mein people used to do for DUB is an old terminology, and just remove the uteruses. This practice has no evidence, okay, and this should not be practiced until absolutely not without making a diagnosis. What am I telling you? That if a patient is diagnosed with cancer, then the management completely changes. It becomes a staging laparotomy. It becomes a workup for cancer, right? So, so first have a diagnosis and then decide on a hysterectomy, not blanket like this, all right? And again, like I said, this small fibroid may not be contributing to her heavy menstrual bleeding at all. Now let's have a look at the next question. See this question, 52-year-old obese, now says 52-year-old, she's coming with postmenopausal bleeding. On pelvic examination, cervix looks normal, flushed with vagina, uterus is normal in size, adnexa are free. Which of the following is the next best investigation for this patient? Right? So if you look at the profile, please understand there is no blanket investigation of, I keep repeating, there's no blanket investigation of choice, there's no blanket next best investigation, right? It is circumstantial. It depends upon the patient's clinical profile. I cannot give you one blanket answer for such questions, okay? So if she is obese, hypertensive, postmenopausal bleeding, right? Which of the following is the next best investigation, and you have to choose one. So now see, you were asking me about guidelines and recommendations. So ACOG recently updated its guidelines on postmenopausal bleeding. That was something that we used to follow any which ways. That is, cater the investigations according to our needs. So both TVS and endometrial aspiration are first line investigations. They serve different purposes. What TVS can tell, endometrial aspiration will not be able to tell. What endometrial aspiration and histopath will be telling, that TVS cannot tell. They are not a substitute for each other. They will tell two different things. TVS will tell about the structural lesions, right? So TVS may be able to pick a uterine enlargement. TVS will tell about the endometrial thickness. TVS will tell about maybe if there is a fibroid that has probably become symptomatic for the first time in a postmenopausal woman, or TVS may pick up a uterine mass which could be a leiomyosarcoma. So TVS answers different set of questions, right? Now they said that TVS, if it is more, ET if more than or equal to 4 mm, then we do endometrial aspiration, right? Now they are saying EA is first line, because EA is first line. Why? Because they are saying that, okay, your type 2 histology, and there in those countries, in American population, the incidence of endometrial cancer is on the rise. In our country, endometrial cancer, maybe in the affluent societies, yes, but we're still struggling with cervical cancer. So I won't say that our incidences of endometrial cancer are like the American standards, but even then, endometrial aspiration, endometrial cancer can arise even in thin atrophic endometrial lining, and that is the type 2 serous histology, actually the more dangerous and the more aggressive histology, right? So now they are saying that in the first episode itself, they are saying do both if possible. They are both first line, do both if possible wherever, and only in limited people they are saying that TVS alone would be enough. TVS alone would be enough only if ET less than 4 mm. Okay, definitely clearly seen, absolutely no risk factors at all, and willing for follow-up. This is very, very crucial, willing for follow-up. Okay, so in our patient, most of the times what happens is that we can't really ask them, okay, we tell them, come when you bleed again. This was your first episode, I have done your TVS, right now your ET is less, let's call you up later. How later? How many times later? Come later when you bleed again. She never comes up for follow-up, or she can't come up for follow-up, whatever circumstances are. So patient lost to follow-up, then we get to pick up the cancer in late stages. So the justification is this. The idea is do both. So much of this explanation to drive one simple concept, that the priority is not to miss cancer in these women. Okay, priority is not to miss cancer in these women. They both tell different things. All right, obviously if ET is more than or equal to 4 mm, there is no doubt we have to do endometrial aspiration. Now they are saying do it in the first visit itself, even if ET is thin. Right. So with that logic, and even when we used to do it in our setups, see, uterus is normal in size, adnexa are free. Clinically, I am not really thinking that uterus is not enlarged. I am really not suspecting anything in the uterus. For me, priority is endometrium. If this was the patient and she would tell me, doctor, I have money for only 2 investigations. Either you get TVS done or I will pay for endometrial aspiration and histopath. Cannula also you will ask me to buy. And then histopath you will send, that person will also take money. So, if that was the patient telling me, please doctor do one, I will say, okay, I will do endometrial aspiration then. I have justified, okay, from my end I have justified that I will choose endometrial aspiration as the answer and not pap smear and not hysteroscopy, right. So, if you have persistent symptoms, even after normal endometrial aspiration, then you go for hysteroscopy guided biopsy, okay. So, this is for this particular situation. Now, let us have a look at image based question. One I have left, I will do it with the image based question, I will add it there. Let us do this question. 18-year-old girl presents with complaint of primary amenorrhea. She has well developed breast and pubic hair. Vaginal introitus looks normal on local examination and the cervix is not felt on perrectal examination. What is the likely diagnosis? So, I have 3 questions of amenorrhea to help you understand how to attempt these questions. Another image based question I will add with image of PCOS, I will add with the image based questions, okay. Yes. What is the answer here? What is the likely diagnosis here? Mullerian agenesis, excellent. Mullerian agenesis. You are coming with the doubt, but your guess is all very correct. Mullerian agenesis is the answer. The androgen insensitivity syndrome will not have pubic hair, okay. Pubic hair are going to be absent or scanty, they will write, okay. Fine. So, when you look at the options, try to recall that what are the keywords. Keywords also you will have to look for the options that are in the question. Uske beyond you don't have to think while attempting questions, okay. So, primary amenorrhea, well developed breast and pubic hair. So well developed breast and pubic hair. A pubic hair absent or scanty androgen insensitivity syndrome, that is not your answer, right? Vaginal introitus looks normal on local examination. So that could be with transverse vaginal septum also, but cervix is not felt on per rectal examination. Cervix not felt on per rectal examination, meaning most likely uterus is absent. Most likely uterus is absent. Turner syndrome, different profile. Turner syndrome, breast development absent. Height short and everything. Okay, so this is out. Transverse vaginal septum will have some or the other history suggestive of cryptomenorrhea. Cryptomenorrhea. History of cryptomenorrhea, findings of cryptomenorrhea, a bulge in front of the rectum, right? And cervix should be felt, something like that. So it is not going in favor of transverse vaginal septum. All findings are going in favor of the best answer to choose from among the lot is Mullerian agenesis. There is no better way to attempt these questions than by elimination, is what I have figured out. Okay, because flowchart magically does not appear in front of our eyes. It doesn't appear magically in front of our eyes that you see, okay, this was there, then this, then this, then this, then this. It doesn't happen like that. Flowchart is for recall, in the sense that when you are going through the flowchart, recall the principle of what that flowchart means. Okay, so here the answer is most likely Mullerian agenesis, and further confirmation, yes, you will need a karyotype, right? Further confirmation, you will need a karyotype, very, very important. Now next question. 14-year-old girl is brought by her mother with complaint of absent breast development and not having started menses. Okay, so primary amenorrhea, there is primary amenorrhea, absent breast development. Okay, most likely cause, look at the options first. So that will help you what you need to look in the question. Androgen receptor deficiency, meaning they are talking about androgen insensitivity syndrome. 17 alpha hydroxylase deficiency. Now you can attempt these questions if you have an idea about what these options involve. So 17 alpha hydroxylase deficiency, this enzyme is needed for androgen synthesis. 21 alpha hydroxylase deficiency is congenital adrenal hyperplasia. This is also actually a rare form of congenital adrenal hyperplasia only, right? So what is your correct answer? Yes, most likely cause. All of you are saying B, and there is one person who is saying D. Some of you are saying B. There is absent breast development, not having started menses, girl is tall and well built, deepening of voice, and there is cryptoromegaly, and bilateral inguinal masses, pubic hair are absent, uterus cannot be felt on per rectal exam, serum testosterone levels are markedly elevated. What is the most likely cause? Okay, right? So now let us eliminate. These inguinal masses, bilateral inguinal masses in a girl born and brought up as a female. She's female for all practice. She's born and brought up as a girl, and now she has bilateral inguinal masses. In this clinical context, these masses are almost always testes. In this question, they may have given you that the karyotype is done and the karyotype is 46XY. Okay, when that is the situation, your 21 alpha hydroxylase is out. This is 46XX karyotype, right? And this is excess androgens. It also has virilization. This has virilization. Okay, this also has excess androgen production, but the karyotype is 46XX, and in these situations there will not be these inguinal masses or anything. So I am not going to pick that as an answer, right? And there is the and if you look at option number D, yes, 5 alpha reductase deficiency. Those of you who are saying 5 alpha reductase deficiency, that is the correct answer. 5 alpha reductase is required for the conversion of testosterone to DHT, right? So here there is, this is 5 alpha reductase. So deficiency will cause increased testosterone, right? So it will fit. It will fit with the features of virilization because there is excess testosterone. Serum testosterone levels are markedly raised. It will fit there also. So this is most likely fit. Why 17 alpha hydroxylase not the answer? Because this is the enzyme needed for androgen synthesis. If androgens are not getting synthesized, how will there be features of virilization? 17 alpha hydroxylase got ruled out. 17 alpha hydroxylase got ruled out because there is no virilization. Because there is no virilization. Okay. Now, I understand when you say no, you always forget this type of questions. You always forget this type of questions because the flow chart does not magically appear in front of your eyes. Okay. There is a flow chart that I keep giving to my students, but the whole idea is I also don't mug up the flow chart. मुझे भी नहीं याद है flow chart. I'll have to probably write it down and go step by step, and then I will be able to recreate it for you. The idea is that you remember what this means, and then you eliminate in the options. Otherwise, you waste too much time on such questions. Okay, right? Yes, yes, FSH and LH will increase in 17 alpha hydroxylase deficiency. Yes, you are right, Reshma. Right, this will be hypergonadotropic hypergonadism because estrogen deficiency will be there, no? Androgens are not there, so estrogen deficiency is also there. So, estrogen deficiency in FSH LH will be raised in 17 alpha hydroxylase deficiency. And again, adding from your peds and from your medicine, they will also have hypertension. And androgen receptor deficiency is not the answer because they will have breast development. Okay. All right. So, 5 alpha reductase deficiency is your best choice answer. All right. Now, moving to the next question. This also is a recent PYQ. 37-year-old girl, 37-year-old woman, amenorrhea for 9 months, no withdrawal bleeding on progesterone challenge test, physical examination normal. If you look at the options, pituitary failure, uterine synechia, PCOS, premature ovarian insufficiency. 37-year-old to be having amenorrhea for the first time here, and with PCOS very unlikely, right? So, I know what to read, I know what to look for in the question, all right. Dryness during sexual intercourse, all of this dryness during sexual intercourse, no withdrawal bleeding even after giving progesterone from outside, meaning estrogen deficiency must be there. That's why endometrial buildup was not happening. That's why dryness during sexual intercourse. FSH 36, AMH on the lower side. AMH is not making the diagnosis. FSH is making the diagnosis. Elevated FSH is making the diagnosis for you. What is the diagnosis? Very good, premature ovarian insufficiency. Uterine synechia mein they may have given you a history of multiple curettages. They may have given you a history suggestive of genital tuberculosis. These are the two situations where we tend to encounter uterine synechia, and the hormone profile has to be, hormonal profile is normal, hormonal profile is there. If pituitary failure is there, then you will have decreased FSH, right? So, much of the read, that is how you will attempt fast. You will see FSH level of 36, that is elevated. Reproductive age group female, 5 to 20 is the normal range, 36 is on the higher side, more than 25 I am concerned in that clinical context, right? So, FSH is not low, FSH is not normal, it is high. AMH is also low in this woman. PCOS hormone levels are more or less within the normal range. It is the ratio that is problematic, right? And so, we are left with premature ovarian insufficiency. Most of the times the common cause is idiopathic, and then the second most common cause is autoimmunity. Second, then we have fragile X carriers, fragile X pre-mutation carriers also. Okay. And for somebody who is having premature ovarian insufficiency, if she is less than 30 years of age, then we also look at the possibility of X chromosomal abnormalities like Turner mosaic or something. All right. Now, most common cause of postmenopausal bleeding in India, endometrial atrophy or cervical cancer. Cervical cancer overall. Okay. Normal level of AMH, AMH of normal level नहीं था, AMH का normal, AMH only tells us about the reserves, that's all. That is why AMH is not used for making the diagnosis only. AMH आपको बस एक side clue, AMH given here was just a side clue. Okay, AMH less than 1 is considered low reserve, it's considered as poor reserve. उसमें भी the more lower it is on the lower side, it is the worse it is, that's all. Right. So, AMH varies across age, na? AMH is age dependent. and usme bhi AMH is like, for somebody it may be on the lower side, but she may not be having amino. It means not just low reserve. It's in the context of infertility is analyzed, and it means poor reserve. And it also doesn't mean that somebody who has a low AMH doesn't mean that she cannot get pregnant on her own. It's not like a what do we say, sentence from God that no, it cannot happen. It simply means that if we do give ovulation induction in these women, we use gonadotropins, we may need to give higher dosages. So it just maybe changes our treatment strategies or IVF induction protocols a little bit. So that's the idea of AMH. Okay, fine. Next question. Right. So a 30-year-old woman had a now see, there was a copper-T related question in FMG recently. They have been asking clinical questions on contraceptions a lot. I have added an image to this question. Now, 30-year-old woman had a post-placental copper-T insertion. I want you to remember from the stem that yes, post-placental copper-T insertion can be done within 10 minutes of placental delivery. Within 10 minutes of placental delivery, that would be, yes, that would be a good time, and that would be ideally, yes, postpartum. When we say copper-T insertion, we mean within 48 hours of delivery. Okay, when we say postpartum insertion, that means within 48 hours of delivery. If we miss this opportunity, then after 4 weeks we will put, after 6 weeks we will put, after 4 to 6 weeks actually, right? So this was post-placental copper-T insertion inserted 6 months ago during a cesarean section, but she cannot feel the threads. She is asymptomatic with regular periods. UPT is negative. TVS shows the following findings. Most appropriate next step, yes. Yes. So the image here, so they could give you a question where they have described the image. That a scan was done and the copper-T was seen inside the uterus. Okay, here you are seeing this bright white line you are seeing inside the uterine cavity. This is the uterus. This bright white line you are seeing, this is a perfectly placed copper-T. Okay, and I will say that this is a perfectly placed copper-T. It is right there in the center, right? It is. She's also asymptomatic, no? It's not like she's having some pelvic pain or she's having bleeding. She's having regular periods, right? So it shows that the copper-T is inside the uterus, right? So you need to just reassure her, tell her that you are seeing the device correctly and no further imaging is needed. Now, obtaining a plain X-ray to locate the device would be done in case the uterus was empty. In case the uterus was empty and we did not see the device inside, then we would wonder whether the device has perforated and gone inside the abdomen or pelvic cavity, or the device was expelled already. So then it is needed. And laparoscopic removal I will not do for presumed perforation. No, I will first do an X-ray abdomen pelvis. Then if I find that if it is inside the pelvis, then I may think of doing laparoscopic removal. And removal and reinsertion, for the reason that the device is perforating the myometrium? No, the device is not perforating the myometrium, very unlikely. It is correctly cited. She is asymptomatic. It doesn't need removal and reinsertion. But now I will add another thing to this. Supposing they changed the clinical context, and they had asked you that there is a woman who is seen, she cannot feel the threads like this, she cannot feel the threads, the image is there, they tell you that the copper-T is inside the uterus, and she is wanting to remove the device. Let's say this. So what happens is many times the copper-T thread is inside the cervix. Because see, there is some reason for removing the device. Whether she has requested is another matter, alright, that could be the clinical context. But it has been decided that removal needs to be done. So what happens is sometimes the thread may be coiled inside. So we have a copper-T hook. Sometimes we don't have the hook, we have a small curette, we can use that also. Or we have this endocervical brush also. So we can move the endocervical brush inside the cervical canal. Sometimes the thread is coiled inside, remove it, take it out, job done, and then we can pull out the copper-T. Right. Now, if on the endocervical this thing also the thread doesn't come out, then yes, we need to go for the scan. Scan we do. On scan, we know that it is inside the uterus now. Now, if we have to remove, we can try hooking out with a copper-T hook or a curette. If that works, fine. Otherwise, then she may need hysteroscopic removal. Maybe it is a deeply embedded copper-T. Clear? So, I told you about 2 more scenarios here. sorry, one more scenario here, all right, okay. I think there's a lot of lag happening because from what I see is that, all right, yeah. Next, last question. A young woman was prescribed low-dose combined oral contraceptive pills. She returned after 1 month with complaint of spotting episodes, and she is concerned about the failure of the method. She is counseled all of the following except. What will you not tell her? What will you not tell her? She is given low-dose combined oral contraceptive pills. When I say low dose, that means 20 microgram ethinyl estradiol containing. And with these kind of pills, when particularly the estrogen content of the pill is decreased, then this breakthrough bleeding, she is experiencing breakthrough bleeding. She is experiencing, this is what we call as breakthrough bleeding. This is the most common side effect. Please keep that in mind. And especially with these lower dosages, the lower dosage combined hormonal contraceptive pills. Think of it like the uterine lining or the endometrial lining adjusting to the new hormonal milieu, because the effect of combined pills, the effect of these combined pills, that is estrogen and progesterone containing pills on the endometrium, is more of progestational in nature. Progesterone predominant effect hota hai, thins the endometrium. That is why it leads to, it gives relief with abnormal uterine bleeding also. So, or heavy bleeding also. Women who can take pills, they tend to have less amount of bleeding during their periods. Remember it like that. Okay. Now, when we decrease this estrogen content in the pill, it can lead to too much thinning of the endometrial lining, and then breakthrough bleeding happens. So, it is like the uterine lining is adjusting. It most of the time resolve on its own in a couple of months, in about 2 to 3 months. So, all you need to do is to counsel the woman. She is worried about whether the method will fail. Well, if she keeps taking the pill consistently, the method will not fail, right? Or it would not increase the usual failure really. I mean, we can't say the method will never fail. We can say that there is no increase in failure rate other than the usual failure. So, she should continue the method, yes, with consistent use. If she is not forgetting the pills, if she is regularly taking, there is no increased risk of failure of the method, yes. And this is most likely to resolve in the next few months, yes. She should be switched to another method immediately, not necessary. I mean, we can keep a watch, and if she then requests, okay, no, I am not comfortable with this, it's not working for me, and she requests being switched to some other method, of course, she can be switched to some other method, but not, I mean, not straight away, right? So, C is your answer. Yes. All right. All right. Now, Kajal, if you feel that the LRR and YouTube questions have become tough, then probably you've not been seeing my videos more of. These are much of the questions I often discuss. And yes, they have, see, it's not about, don't think that this is tougher. Don't take it as this is not your test. When we are having this discussion, it's not like I am testing you or anything, or you don't have to think of it like this, that you don't know the answer, you are having difficulty. The whole exercise of thinking, answering, maybe making the wrong attempts, or maybe challenging what you know, or maybe sometimes we even remember a correct statement in a very incorrect conceptual manner. You may be remembering the fact correct, but you're not using it in the correct context. So that discussion is what matters, right? So I will not say tough questions, but I will say good question. I am not saying that these questions are going to get repeated in your exams. Yahin se aayega, idhar se aayega. I am not saying that. Please understand that the idea is to revise a topic in a manner that you are able to attempt questions from that topic, whatever is thrown at you. Something that is going to be one-off is going to be one-off for everybody, right? Right? Now, Leena, LRR and video based questions will be enough for OBG. LRR would be enough I will talk for my this thing, LRR would be enough if you have done a previous study. If this is your last minute revision, but you have put in time and effort in OBS Gynae, then LRR and visual based images can be enough. But if you will say that no, I have not studied OBS Gynae and this is right now I am doing only LRR and straight away this is the first time I have suddenly woken up and I have decided that I will do LRR and image based sessions and that would be enough, then I can't give you that false hope also, no. That will be very difficult, that such a huge subject from LRR only everything will be covered. But if you have done the groundwork and then you just need it for revision purposes, then yes, it can be enough, but that would also maybe 80%, right? Beyond that is wishful thinking. All right? Okay. So if you have studied but not revised, then yes. If you have studied but not revised, then you can pick up the LRR, but again then you will have to do the question module. Then you have to do, then Twilight is answering for you. Then you will have to go for the PYQs plus custom modules, and then you go back to your notes of RR or whatever notes you've made earlier in a retrospective manner. ठीक है? Okay, so we'll end the session for today. Okay, we have an LRR coming up in the app also, and we have the image based questions which is going to be done on the YouTube. All right. Okay, Vijay, yes. Regarding recent updates in OBS Gynae, what's your advice? Okay. Postmenopausal bleeding wala is correct, right? And then your recent update is regarding WHO updates are more relevant. WHO updates are more relevant wherever they are. Okay, so like the PPH update came from WHO, that is very relevant because that is something that we had also been practicing. So WHO ka PPH wala is relevant, right? The vaccination drive that they did on HPV, that is very relevant, and your the postmenopausal bleeding recommendation that came, I have talked about that also, right? And AMTSL का चेंज, AMTSL यही तो है, बता तो दिया, ऑक्सीटोसिन immediately after delivery of the baby, 3 drugs that we can use, the methergin हट गया, second is delayed cord clamping, then controlled cord traction, right? And intermittent uterine tone assessment, वो the whole point is, देखो क्या होता है ना कि when WHO draft, अभी देखो, you will find it very, now that you have asked me, I'll tell you changes. When the WHO initial published था, they had written AMTSL, active management of third stage of labor, 4 things they had written. ठीक है, uterotonics immediately after delivery, delayed cord clamping, then delivery of placenta by controlled cord traction, then intermittent uterine tone assessment should be done. Uterine massage is not recommended. ठीक है, so obviously we have already delivered the placenta, third stage is over. So technically speaking, yes, we were anyways, even if we were doing uterine tone assessment, it is technically in the 4th stage of labor. So इसमें क्या हो गया, इसमें नया क्या है, right? It is a component of 4th stage of labor. Of course, intermittent uterine tone assessment, even with what they had written earlier in the AMTSL paragraph, right, that we were anyways doing after the placenta was removed na, so technically we were doing it in the 4th stage only. So yes, it is in the, it's a component in the 4th stage of labor. पहले भी ऐसी था, but just that in the first document that the WHO had for many years, it was written under the AMTSL recommendations. करते हम उसको वैसे ही थे, right? Understood? Okay. And then there is these, thyroid, American Thyroid Association recommendations. That is also relevant. That's also relevant. Because अब हमारी practice भी वैसे ही रही है. That's actually relevant. That is because that हाँ, तो That is also relevant. Okay. Chalo then, I think it is going to be 8:30. We've had a long session today, right? So we're going to end for now, right? Okay. This session became an LRR session only. I thought I would challenge you guys and we will go for the PYQs and we will just write the answer and then move on. But somehow it didn't happen like that. Okay. Vishal, beta HCG is high, but the patient is hemodynamically stable. How high? If beta HCG is more than 5,000, then I would not like to prefer. The criteria for medical management is beta HCG should preferably be less than 5,000. Cardiac activity should preferably be absent. And less than 4 centimeter size, stable patient, willing for follow-up, right? So, I will not make the decision only on the HCG value, but HCG on the higher side, I will not prefer. Now, regarding diabetes in pregnancy and management, join the LRR. Okay. Divine diabetes in pregnancy and management. It depends upon the whole idea is about blood sugar control. Okay. So, if it is GDM, just to give you a broad idea, Ahmed, if it is just plain simple GDM and the sugars are not in the overt range. Okay, overt range sugars are fasting more than 126 and 2 hour postprandial more than 200 or 2 hour post 75 gram OGGT more than 200. Okay, so blood sugar levels in the overt range, you do the diet, medical nutrition and all that, but you also start insulin simultaneously. If blood sugars are in the GDM range, meaning they are not in the overt range, then we can give a try for 1 to 2 weeks of diet therapy and exercise, and then we can see at a later point in time, follow up with sugar profile and see if the sugars are getting controlled. If the sugars are not getting controlled, then we will add insulin. That's the difference. Okay, and the whole idea is to take the pregnancy as far as possible till 39 weeks, as long as the mother and baby are doing okay, in simple terms, right? So, sugars getting controlled, right, baby doing well, and your fetal monitoring is doing well, and your mother's blood sugars are controlled, then take it as far as 39 weeks as possible. Pehle hota tha, GDM we can, plain and simple GDM we can go till 40 weeks also. There's no need to this thing, but more or less, yes, 39 completed weeks, diabetes in pregnancy, whether GDM, whether overt, but sugar control, no other high risk factor, right? Then we can take till 39 weeks, 39 completed weeks, then we can plan for induction. And we may need to go for earlier delivery in case the sugars are not getting controlled. Right? So, mota, yes, that is the idea. Okay, right? So, I think I have answered that question. Now, I'll end the lecture for today. I'll end this session for today and I'll see you soon next. All right. So, 12th is the LRR, today is 10th, yes. 12th, so day after tomorrow is the LRR on the app, and then on 14th, we're meeting again for the quick image-based revision here, right. So, you can join either of the two because LRR will also cover a lot of your images, right. So, you can, cherry pick which session you want to attend. अच्छा एक बंद कर दिया क्या? Okay. Okay, so yes, I know even you are saying that even after RRR and main videos, if you're not getting confidence in solving the MCQs, then you have to analyze deeper, bache, that where you are making mistake. Abhi, you can only answer yourself, right? Okay, a problem is where are you reading the question incorrectly, or or it is a conceptual gap. Because see, LRR is very fast paced. LRR works on the idea that you have a basic knowledge of the subject and you have read from zero. You have that ground knowledge there. You have done that bit. And LRR works on top of that. So, one reason why you feel that LRR mein you spend a lot of time, and at that time it makes everything make sense because I am giving you the answer. I am telling you look at this. So, you are looking at that with me. But when you are left to read question on your alone, then you are lost. So, I think maybe that is what you are going through, right? So, you get a second thought. Right. So, as long as you are doing it with me on the YouTube or wherever or while reading with the notes, you feel वो आपको you feel falsely that you know, right? So please just look deeper as to where you are making mistakes, because if that is the situation that conceptual clarity is not there, then maybe you will have to, you know, look at those weak areas where you're not being able to. So thoda sa smart ho jao, abhi to exams are very near, but maybe you need to look up those areas where you are weak at from the main videos. So I think the reason for falling short, or the reason for fumbling in too close options, is mostly because of conceptual this thing weakness. Okay, so that is what I can say. All right. I'm just looking at Dr. Princey's question. It's such a long read. Can we give anything to RH negative mother and RH positive father who had first baby RH negative and second baby RH positive and now planning for third? Is there anything that can be? No. No. I mean, nothing needs to be given pre-pregnancy. Okay, second baby was RH positive, so she may have gotten during that delivery or during that pregnancy, she may have gotten this routine antenatal anti-D prophylaxis, mila hoga. Even if she has not gotten, now a third time pregnant, just manage her. Again, ICT. Start with that first visit ICT to know whether she is sensitized right now or no. In between pregnancies, nothing is done. Okay? Yes. Now sarcode, what we are having a brushing up concepts. We are having this LRR, na bacha. We are having this LRR day after tomorrow on the app. Okay, where I will be doing clinical, where I will be doing clinical flowcharts. So I will be talking about, again, the idea is to cover as much as possible in limited time. So I will be doing clinical scenarios mostly in the LRR also. Okay. All right. Chalo. Ending for now. Bye guys. Take care. Good night. And wait up. We'll meet again and we'll see up. I'll see up your questions again. And even if you have questions, you can put it on the chat box or the comment box. You know, I mean, I'll respond to that later also. If I'll miss out on it right now, then I will respond on it later. Okay. Okay.